You know the funniest part? Some doctors have shared the yesterday's link outside the group. You so right. I don't know who are doing this every time, but it's okay. Anyway, they can't access the file without my permission. Only few doctors in the group are still sharing outside, right? Actually, if I catch the person, I will remove the person like who are doing that, right? Because they should respect, right? Yeah. Okay, start. Okay, today's part two, 75 pages only. Okay, so next question. Old age smoker, painless hematuria. What to do next? Okay, this is the question. Yeah, I'm doing good, doctor. How are you, Dr. Grace? Okay. Yeah, yeah. Someone has again shared the link outside. So I was telling every time there's someone who's sharing the link outside. So yeah, if I find out, I will remove that person as well. That's the one I was telling. Yeah. Okay, it's totally fine, doctor. Anyway, they can't access my file without my permission. Okay. So here, all age smoker, painless hematuria. What to do next? Yeah, yeah. Okay, so what do you know about this hematuria? We'll quickly discuss about hematuria. So what is hematuria? It's a presence of red blood cells in urine, right? So we have two types, microscopic hematuria and macroscopic hematuria, right? So microscopic mean that we can't see on the we can't visible it on by our eyes, but we can visible it from the urine microscopy. So macroscopic mean the visible hematuria, right? We can see by our own eyes. So there's a main thing that you need to remember: painless macroscopic hematuria in adults. Always you have to exclude the malignancy until proven otherwise. The painless hematuria, right? Very important. Okay. So what are the causes of this hematuria? And we have the transient, right? Exercise induced or trauma due to sexual intercourse or pelvic organ prolapse, vaginal atrophy. Due to these causes, there can be a transient hematuria. So other one can be malignant related, right? Urothelial cancers, prostate cancers, renal cell carcinomas. These are the other malignant related hematuria causes. So there can be infectious inflammatory. So if there's a pyelonephritis present, it also can be hematuria present, like or low urinary tract infection, radiation cystitis, foreign body, urethral uh, caruncle. Those other things. So other can be renal medical disease like immunoglobulin A, nephropathies, those things. So hereditary nephritis. So it can be obstructive as well. Right? If there's a renal stone present, that also can cause the hematuria. So usually we remember this hematuria as if it is a painful hematuria, we have to think about the stones mainly as obstructive cause. If it is a painless hematuria, you have to think about what the malignancies, right? Yes. Yeah, here's the painful hematuria, stones or infection. Think about malignancy with proteinuria and hypertension. You can think about some glomerular disease, right? Yes. Okay, so investigation approach. So there are two tables. Okay, two tables here from the two different RSCGP guidelines. I have attached both of them. But here we'll discuss this investigation from some questions. Okay. A 65-year-old man presented to the GP clinic with a 3-week history of intermittent passage of blood in urine. The blood is mixed in with the urine and not associated with any pain. He has no significant medical history and do not take any regular medications on examination. He appears well with vital signs within normal limit. Digital rectal examination revealed moderate smooth enlargement of both lobes of prostate. Urine analysis and urine culture are arranged and urinary tract infection is ruled out. Recent serum biochemistry and electrolytes within normal ranges. They asking which one of the following most appropriate next step in management. So, what do you think? Type in the chat. What do you think, doctors? 65-year-old man, painless hematuria. What about other doctors? Okay, here. So answer is CT urogram with IV contrast. The patient has a 3-week history of frank hematuria. In all cases, macroscopic hematuria, benign cause must be assessed with the preliminary investigation such as urine analysis and urine dipstick performed as in this stem. So following a negative urine culture, malignancy must be considered and excluded, right? The patient will need pelvic and abdominal imaging, well as cystoscopy. In practice, as this patient has presented to GP, it will be easiest to get some imaging performed before the patient see a urologist. A CT urogram with intravenous contrast is required for patient with gross hematuria, as the IV contrast line the collecting system and ureter, which will identify any filling defects such as urothelial carcinoma as well as solid renal tumor or urinary tract calculi. While cystoscopy and other invasive investigations are the most sensitive for detecting malignancy, it is most feasible for GP to organize for an image while the former is being organized, therefore making CT urogram with IV contrast the most appropriate answer. Right? Okay. Yes. I hope you understand it, right? So we'll move to the next question. We'll move to okay, why not CT urogram? Non-contrast is used to look for urinary tract stones and may miss the pathology such as solid renal tumor or urothelial carcinoma, right? Okay, why not? Ultrasound is often used to investigate is used to investigate microscopic hematuria as it is relatively non-invasive, use no radiation and may identify solid renal tumors or hydronephrosis. Results are reasonably operator dependent. The ultrasound has only approximately 40% sensitivity for identifying the renal tumor. So, given that patients with a macroscopic hematuria are at high risk of renal tract malignancy, so then CT urogram is most appropriate, right? I hope you understand. And what about cystoscopy will be needed to investigate the lower urinary tract. However, first of all, it must be determined whether it is there any upper tract pathology such as suspicious of urothelial carcinoma. If an upper tract issue is identified, then uteroscopy can be performed at the same time as cystoscopy. Right? So this is the theory you need to understand. So renal cell carcinoma should be considered and excluded in all patients with persistent frank hematuria. Right? Okay. Here, what do you think? 66-year-old man presented to uh, GP practice city clinic with a 2-week history of intermittent painless hematuria. Has no other urinary symptoms and he has no significant medical history and no regular medications. 45 pack year smoking history and currently smoker 10 cigarettes per day. He drinks about 2 glasses of wine most days on examination. He appears well with vital signs within normal limit. Abdominal examination revealed no abnormalities. Microscopic examination of urine confirmed the presence of red blood cells. Which one of the following is most appropriate next step in management? I know you all know the answer. The patient present with painless hematuria, which required through the investigation due to the high risk of underlying urological malignancy, particularly given in the significant smoking history. The approach investigation hematuria involved the imaging of the upper urinary tract and direct visualization of the lower urinary tract. So, CT urogram is most appropriate initial investigation in this case, right? So, let's go back to our case. So, old age smoker, painless hematuria, what to do next? So, they have given CT abdomen urodynamic study ultrasound. So, we assume this as a frank hematuria or gross hematuria. In that case, you have to go with CT urogram because most of the time they are given in old case with frank hematuria. And what to do next? It should be a CT urogram because you need to exclude all these malignancies, right? I hope you have understood the two below questions. Is everything clear about this investigation? Because you need to get a before going with these cystoscopy those things, you need to take images because like it's very accessible for the GPs to take a CT urogram while preparing this patient for the further referral, right? So in that case, the first line investigation, if you're suspecting any urological malignancies with frank hematuria, painless frank hematuria, in that case, you need to go with CT urogram. This is the most appropriate one because ultrasound is not very important because sensitivity is like a 40%, right? So look for the CT urogram, right? Is understood? Understandable, doctor, or not? Yeah, also they have mentioned in yeah. CT IVP is a gold standard for assessment of the urinary tract malignancy. So in that case, it's a uh, anyway, GP can arrange this CT-IVP for patient if they are suspecting any urothelial malignancies, right? If everything is understandable, right? Okay, here we'll discuss about this chart as well quickly. History with hematuria. So anyway, initially we have to do the urine analysis and you have to exclude if there's UTI present or not, right? So first you have to exclude non-neurological cause, UTI or transient, benign cause suspected. So repeat microscopy within 6 weeks, like that. Then if it is a macroscopic hematuria, image in no adjunct, so CT-IVP or renal tract culture sonography. But we know from these two, CT-IVP is the best one, right? Then after that, urological referral you need, right? So if it is a microscopic hematuria, it's more than 3 RBC. So, then you have to think about the risk stratifications. Doctors, just give me 1 minute. I'm getting a call. Sorry for that. Yeah. Okay, so macroscopic hematuria. So, sorry, I was in here. So you have to do the risk stratification. So risk stratification mean age, presence of risk factors. So what are the risk factors? These. So risk factors are age more than 50, smoking history, occupational exposure, irritative lower urinary tract symptoms, history of gross hematuria, prior pelvic radiotherapy or recurrent urinary tract infection. In that case, I do the risk stratification. Then if it is low risk, you can consider repeat microscopy within 6 months. But if it's risk factors present, anyway, you have to follow this pathway because if, as example, in our case, even though our patient is having microscopic hematuria, our patient is elderly one, right? Elderly more than 50, that means the risk factors. So in that case, you need to anyway exclude the malignancies, right? I hope you can understand this, but it's a very good one. Okay. So give it a rate. Okay. Yeah. So next one, 80-year-old lady developed severe back pain after bending, past history of colon cancer diagnosis. So what do you think? What do you think, doctors? What do you think, doctors? Tell me, doctors, like, give your opinion. What do you think? Because this question is kind of like perhaps actually we need like some more details, but we'll discuss. Okay, before that, tell me. Okay. Yes. Okay, why you are thinking it as the compression fractures? Give me the like points, the reasons why you are thinking it as compression factual fracture. Why? Elderly, right? Elderly, 8 years, very old, right? And patient is having is after bending, eight after bending, right? Severe back pain after bending. Okay. Mm-hmm. Yes. Okay, doctors. Yeah. Yeah, that's the reason you are going with compression fractures, right? Yeah. Okay. 1 minute. Okay. Who can tell me what are the red flags for the back pain? What are the red flags for the red flags for back pain? Tell me, doctors, what are the red flags for back pain? Because I have explained multiple times how to remember, even in our theory class as well. Do you remember about the tuna fish? Does anyone remember the tuna fish? Yes, right? Yeah. Because even though we know this is a compression fracture, because there's another question other recaller has given sudden vertebral pain after minimal trauma in elderly women, and they have given the osteoporotic compression fracture. Even though the next day they can ask from one of this, because here they have given some history of colon cancer, because something related with the colon cancer as well, right? Because if there's a history is present, it also can be a red flag, right? Yeah. Okay, here red flags of back pain. So you can remember it as a tuna fish. So T mean trauma, U mean unexplained weight loss, N mean neurological symptom, and A mean age less than 20 or more than 55. Just remember 55, okay? Because this part is from me medicine, they have given us a 55. And F means fever or any other signs of infection. I mean intravenous drug user. S means steroid use. And H mean history of cancer, HIV or TB. Like the patient is immunocompromised, HIV, TB, and the history of cancer, because there can be a metastasis as well. So you have to think everything about this when you are suspecting it has a red flag, right? So this all the same thing they have given. This part from e-medicine. Okay, so these are the red flags. If you see these red flags, what you should do, doctors? If you see a red flag, what you should do? If you see a red flag, what you should do? Tell me. Imagine, right? Yes. Okay, that is the other thing you need to understand. If you see these red flags, you need to think about doing imaging, right? Imaging, because there's a red flag present, mean you can't exclude, right? The simple, this is from RSAGP back pain. So indication for imaging include patient with red flags, abnormal neurology or pain lasting more than 4 weeks. These are the imaging indications, right? Imaging indications. So in a plain radiograph can be used to define spondylosis, spondylostasis, scoliosis, important sclerosis, osteophyte formation, loss of disc height if indicated degenerative process. If there is ongoing pain or concern, advanced three-dimensional imaging with CT or MRI is appropriate. CT is often the imaging modality of choice when access to MRI is limited. Otherwise, MRI is best for the our back, right? Yeah. And the author suggests early imaging with MRI under the guidance of the orthopedic spine surgeon if the patient is having severe unremitting radicular pain related to the neurological science, right? Abnormal neurology, red flags, or fail non-operative treatment. Okay, so if there is a mechanical pain present, we don't need to do the imaging, right? I hope you remember. We have done some questions in previous month. I can't remember the exact month. Okay, so don't ask me which month, doctor. If there's only a mechanical pain, there's no need of imaging without any red flags or anything. There's no need of imaging. This is the like a simplest version without red flag, but you are suspecting something fracture. You're suspecting a fracture, then in that case, you can do the X-ray. The neurological deficit or malignancy suspected, you have to go with MRI. These are the like a simple summary you need to understand about this imaging and no imaging part, right? If it is just a mechanical back pain, you don't need to do anything, right? But if you're suspecting fracture, you can do with X-ray. And if there's a neurological features or we are suspecting like metastasis of the some malignancies, then you have to do the MRI, right? Yeah. Okay. Here, I have attached some question. 92-year-old man presented to the emergency department with 1 week history of new onset mid back pain, weakness in leg. which is reducing its mobility and the function. He has a history of metastatic prostate cancer and currently receiving palliative care at home with no active cancer treatment. He has no other significant medical history and take no regular medications. On examination, he appears frail with vital signs within normal limit. Neurological examination revealed weakness in bilateral lower limb, right? Here, patient needs 7 neurological features and patient needs 7 metastatic prostate cancer with their red flags, right? Red flags. So here, neurological examination revealed those things. Then reduced sensation below T10 nerve root, including reduced perianal tone and urgent CT of the office thoracic spine show the metastasis disease at T10 causing spinal cord compression. So if there is spinal cord compression present, there can be a pain. In that case, with these neurological signs and the CT confirmation, you need to do something. So what you should give here, you have to give initial corticosteroid, right? This is some scenario I have attached it for like to get an idea. This kind of questions also they can ask, right? A patient present with the clinical and radiological evidence of malignant spinal cord compression, oncological emergency require prompt management. So most appropriate initiate corticosteroid. So before corticosteroid, you need to do the urgent imaging. Okay, remember these things. Yeah. Yeah, that's the same thing they are mentioning. Okay. So here, okay, now tell me what is a compression fracture? That's for like something extra knowledge. So what is a compression fractures, doctor? So like define it. What is a compression fracture? Tell me. It's a fracture, right? Fracture due to what? Fracture due to some weak bones, mostly from osteoporosis, right? Usually you can see it in elderly patient, right, with sudden back pain. And it's a minimal trauma, right? 1 minute, doctors. Okay, just 1 minute. I have put my iPhone here. Then yeah, I just connected to the my iPhone hotspot. Yeah, doctor. Now it's okay because I just connect my phone to charge from laptop. Then it suddenly changed to the hotspot. Then Wi-Fi has disconnected. Now it's everything good. Is everything clear, right, doctors? Yes, yes, yeah. Live in Sri Lanka, like if you need a proper internet connection in Sri Lanka, you need to have Wi-Fi, right? Otherwise, it's very hard. Okay, so I was telling, usually in elderly patients with a sudden onset back pain with a minimal trauma, right? Like a bending, like something lifting, or even for sneezing and coughing. Also, some very elderly patient with osteoporosis can be there's these compression fractures, right? So why these happening? Most common cause is the osteoporosis, right? Because of that, this vertebra cannot tolerate some small pressure. Because of that, it compress. Then there is this fragility or compression fractures, right? Yes. Okay, those are the things you need to remember. Like, but in not all the cases, there's osteoporosis, right? There can be like elderly patient anyway, they are weak, right? So it can be due to this trauma, or it can be malignancy as well, right? But mostly if there's a malignancy, we can see like more features, right? Not only these things. If it is a metastasis, patient is having more features, more severe case, not like only this, right? Yeah. So, okay, if you're suspecting this one, what you should do next? Okay, what you should do next, doctors? Mm-hmm. Yeah, do you remember if it is from osteoporosis, you have to follow this chart, right? If you're suspecting uh, fracture, you have to go with X-ray, right? Yes, a fracture, right? Anyway, you can do the X-ray. Then it is related with the osteoporosis. Most of the time, you have to I hope you remember that osteoporosis chart, right? According to that, if you are going with the DEXA scan or not, like something different, okay? Yeah, that's the way of going. I'm just explaining. So here, compression fracture. Okay, and I think there's another case. Here also the other recall, just only answer this thing. Please remember the tuna fish thing, okay? I mean, doctor, then there was some other question. It's fine. I will discuss. There's a other question for this X-ray part. Seen later. So next one. Looks like Bartholin cyst. Patient in severe pain. Initial best step. They're asking best step. Initial best step. Pain relief or mass hospitalization. So what are the treatment options we have for Bartholin cyst? Tell me, doctors. What are the treatment options for Bartholin cyst? Okay, here we have different options, right? We have mass utilization, that's the definitive one. And we have the conservative management. Okay, we have conservative management, mass utilizations, and we have I and D with word catheter, not just simple I and D. Okay, I'll explain, okay? Here. Okay, we'll do this question. So 20-80-year-old woman presented to the emergency department with 3-day history of progressive left vulvar pain and swelling. She reports similar episodes over the past 8 months that resolve spontaneously. She has no significant medical history and take no regular medications. She is sexually active with a regular partner. On examination, she appears well with vital signs within normal limit. There is a tender fluctuant 3 centimeter mass in the left posterior introitus at the 8 o'clock position, and the overlying skin is erythematous and but intact. Here can you see this is the Bartholian cyst. Okay? Yeah. So, which one of the following most appropriate definitive management? Here they are asking. Yes, they are asking definitive management. Okay, here in our case, this case patient is having recurrent case, right? Recurrent cases, and there is a symptomatic Bartholian cyst, right? We all know we have symptomatic and asymptomatic Bartholian cyst, right? Yeah, we discuss. Very carefully read this. Okay, a patient present with a symptomatic Bartholian cyst with features suggesting superimposed infection here abscess and history of recurrence suggests need for definitive management rather than a temporary measures. So marsupialization is most appropriate definitive treatment for symptomatic or recurrent Bartholian cyst. It does not telling only for recurrent one. If there is a symptomatic Bartholian cyst also, the main treatment, most appropriate treatment is what? Marsupialization, right? Marsupialization. Because there is some myth, not a myth. Most of doctors are using that, like I have seen. Marsupialization is only for the recurrent case. That is not correct. Can you see? Marsupialization is most appropriate definitive treatment for symptomatic or recurrent pathology. Recurrency is a one indication only, right? And there is a symptomatic. If there is a symptomatic Bartholian cyst is present, and we need a definitive treatment. Of course, the best one is marsupialization, right? I hope you understand these things. Then, this procedure involves creating a permanent opening by a suture in the cyst wall to the surrounding tissue, preventing reaccumulation of fluid, and it can be performed under local anesthesia and has a success rate of approximately 85%. Okay, if there's a patient with a very painful Bartholian cyst, okay, Bartholian cyst, and patient is here and Patient is asking for the treatment. In that case, what you should do? What you should do, doctors? Tell me. What are the options you have? What are the options you have? Tell me. Yes. Yeah, if the okay, because doctor, even though if you are using IND with word catheter, okay, so that what do you mean this IND word catheter mean? Okay, if there's a cyst present, you make a small incision here. That is why incision. Okay, then you put the word catheter inside. Then you keep it. Then that in increase the drainage. That is word catheter and IND, not like the one we usually do the IND, because this always going with word catheter. Otherwise IND we are not only using, because if you do the just IND, there is a reaccumulation of fluid, and again there is a cyst formation can be seen, right? Because of that, we have to use this word catheter and make a incision. Just don't think it's a, remember we have make a incision, then put this word catheter and uh, like uh, increase the drainage. That is the word IND with word catheter, right? Okay. So if the patient is symptomatic, and if you have the best options, like you have an option like a marsupialization, and the recurrence rate is very low, and what is the options you are taking? What is best you can do? Okay, even if it's the initial presentation, even patient is having a severe painful Bartholian cyst, what you can do, doctors? I'm just asking some question. You need to answer me. Mm-hmm. Yeah, because if you have the best thing, and the recurrence rate also very low, if there's something you can do, in that case, why not going with marsupialization, right? Okay, I'll show. Usually conservative management for asymptomatic cases. Okay, here. Yeah, here the success rate is approximately 85% higher success rate is marsupialization. Then they have mentioned most appropriate definitive treatment for symptomatic O. They are not telling symptomatic and recurrent. They are telling symptomatic cases or recurrent cases, right? Yes, O. Then conservative management with sits bath and analgesia may be appropriate for first presentation or asymptomatic cyst. Like can go with first presentation or asymptomatic cyst, right? But given the patient history, in our case, this is a recurrence one, okay? So simple excision of a Bartholin gland carried a higher risk of complications, including bleeding. Anyway, we are not doing simple excision. So broad spectrum antibiotics, no need. What? If there's a pain, can it be? No, 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 no. They are not telling like this. If it is a patient presenting with as a first presentation or asymptomatic cyst, that is two things. First presentation cases or asymptomatic asymptoms, because even though it is a like asymptomatic means no symptoms, right? So in that case, conservative management you can use. Okay. So broad spectrum antibiotics, there's a, like a for cyst, there's a no use. But if there is associated with some infection, you can go with you can give, but it's not like a main treatment option, right? So incision and drainage alone, while providing immediate relief, has higher rate. Here, incision and drainage alone, while providing immediate, give the immediate relief, but has a high recurrent rate up to 20% because the cyst wall remain intact. So what they are doing in marsupialization, they open and remove this fluid, and they are suturing the wall to the here suture in the cyst wall to the surrounding tissue, because there's a again they can't accumulate again because their walls are sutured to the wall, right? That's the best option. Here, it is appropriate only for emergency temporary relief of an abscess if definitive treatment must be delayed. When we are using this I and D, usually we are not using this one, but like if a patient is in very severe pain, and the definitive treatment is late, in that case, for in at the moment to relieve the pain, only we are using INT, right? INT alone, because after that you can do the definitive treatment, because here we are using only if the marsupialization is delayed, right? Yeah. So I hope you get an idea. Okay, in our case, okay, here can you see this is the marsupialization. Here, remove the part, and here marsupialization. There's suture in wall. This wall, this cyst wall into the this surrounding wall, right? So there's a no recurrence. Okay. Okay. Here. Okay, don't confuse things. If the patient is asymptomatic, and most of the time asymptomatic, you can go with sitz baths and those conservative things. But if the pain is presenting, like why we are waiting for the conservative management, right? Why we are waiting for the conservative management doctors, right? You need to do something, right? Because it's very painful. Okay, in our case, looks like a Bartholian cyst patient in a severe pain. Initial best step. So what do you think in here? Tell me, doctors, first answer this one. Okay, I and D with word catheter also option for the symptomatic patients. For the symptomatic patient, it also option, but this is the only guideline we have to use because there's a no Bartholian cyst proper guideline. There are some other UK guidelines, but we should not use them, right? Otherwise, you can be very like misunderstanding, because this is the only one we have to use. This is from e-medicine. So, if there's something related with the Australian guideline, you have to follow it, right? You have to follow it because they have not given, like, they have some Bartholian cyst, some leaflet for the patients only, not for doctors. Just they are explaining something very, like, not even very better way. But what you can get from here? Okay, just write down, because this question I have like explained multiple times. If the patient is having symptomatic, so okay, marsupialization indication, severe painful cyst. Then second indication is recurrent cases, right? This is the best option, overall best option, because best option mean why there's a no recurrence, right? Because you are open the cyst, then you are suturing the cyst wall to the surrounding wall, right? How they accumulate it again, right? Conservative management for usually asymptomatic cases. So first presentation of the this Bartholian cyst, right? In that case, you can use, because like sometimes there can be asymptomatic this Bartholian cyst again and again, right? But without any symptoms, asymptomatic cases, right? Or it's a first presentation of case like that. But most of the time, if it is not asymptomatic, we are not going with conservative management. Remember, conservative for asymptomatic. Remember like that. Simple excision we are not using. Incision and drainage along. Incision and drainage along only use in only marsupialization is delayed. Okay, when then we have something called incision and drainage with word catheter. That is also option for symptomatic Bartholian cyst. But the definitive, the most preferred one is marsupialization. Okay. Other one is IND with word catheter. If the marsupialization is not given in the option, then you can go with IND with word catheter or word catheter, because like to do the word catheter, you need to anyway do the some incision and put inside and um, induce the drainage, right? Like that. So in our case, very severe, painful, and initial and best step. Initial best step is what? So if the best one is okay. Yeah, doctor, we can do it. Like it also not a very very invasive thing. Just you have to do the local anesthesia. You can go it because it's a very severe case, right? Okay. Initial pain relief. For pain relief with what? Pain relief with what? So marsupialization also, like you can release the pain, right? You open the cyst and do the suturing. So pain relief mean your pain relief mean IND, right? When we are using, if the if the definitive treatment is delayed, only we are using IND, because in the symptomatic case also marsupialization can relieve the pain, right? That's the treatment for symptoms, right? Is it understandable? That is the only resource we have to use, right? If the marsupialization present for the severe painful cyst, painful Bartholian cyst, why we are not using it? Why we are waiting time for the other things? Because other options have recurrence, high recurrence rate, right? If you can do the best option as a marsupialization, you must follow the marsupialization, right? Because in later days we didn't get the option as a marsupialization. They have given the option as word catheter. In that case, we can go with word catheter, right? That's another option for symptomatic cases, right? I hope you understand it. Yeah, if it is first presentation, you can go with the conservative management. But here, if it is a severe one, they are asking best option. Why you are not going with definitive management? Why, doctor? Tell me. So here, see here, what is the best option you can go with? What is this? What is this, doctor? Okay, let's see. What is the this is a telegram. What is this, doctor? I don't know what is this. This is a telegram link, doctor. Okay. That's a telegram link, Dr. Grace. Okay, okay. Let's check what you have shared. Okay, I'm just reading it. It's a huge one, right? Okay, I'll open. Okay, one minute. Yeah, because if you are using like other guidelines, they are just given something else. I know that. But you need to understand, right? Like what they are given in e-medicine. Yes, I know, like everyone can go with because the recurrent, that one, the only multiplication given as a recurrence one in that other. I know what you are talking about. There was one chart. I think that is a some UK guideline. They have separated from the 3 centimeter cyst or like complicated cyst, something like this. But we are not using it here. Okay, that's the thing here. Okay, treatment. Treatment of Bartholin duct cyst depend on the patient's symptom. Asymptomatic cyst may be require no treatment, but if symptomatic Bartholin duct cyst and gland abscess require drainage. Okay, for symptomatic cyst, they need drainage. Okay, unless spontaneous rupture occur, abscess rarely resolve in its own. Although incision and drainage is relatively quick and easy procedure that provide almost immediate relief to the patient. This approach should be discouraged because there is a tendency for cyst or abscess to reoccur. Other investigators report the 13% of failure rate of the procedure, furthermore, incision and drainage. Anyway, we know that incision and drainage is not a better one. Okay, because of the recurrence. So, furthermore, incision and drainage may later word catheter placement or mass civilization is different. Definitive drainage involves catheter placement for Bartholin duct cyst and gland abscess and marsupialization for duct cyst. Mm-hmm. Okay, they have given. Yeah, because these both are under symptomatic treatment, word catheter placement and the marsupialization, right? Here they have given word catheter for Bartholian duct cyst and gland abscess. Okay, marsupialization for duct cyst. Okay, but in the option they have given the abscess for the marsupialization. So word catheter, you know how it is used in they are explaining the procedure. Now then see, yeah, the same thing I have explained after the incision made, word catheter inserted and the balloon tip is inflated. Then remain with the cavity for the cyst or abscess. Then like increase the drainage because we are not taking a blood. We will keep it for I think 2 weeks. Yeah, here 4 to 6 weeks we have left the place. Here word catheter. 6 baths taken 2 to 3 times daily. Then marsupialization and alternative to word catheter placement is a marsupialization for Bartholian cyst. This procedure should not be used when an abscess is present. Yeah, this is something different, doctor. They are giving. This is procedure not be used when an abscess present. But in our case, they have given abscess and they have using this one, right? The marsupialization. So anyway, you have to answer like very. This is this question. Actually, there's no proper guideline. So I can tell this one. For the asymptomatic cases, you can use conservative management. Okay. For the symptomatic cyst and the recurrence ones, you can use the marsupialization. Like other option is IND with the word catheter. Those are the two options for the symptomatic cases, but they prefer marsupialization as a definitive treatment in e-medicine. I don't know about that reference, but here I'm following only this reference. Okay, this is the only one we have, and they are advising use IND only if the definitive treatment is delayed, right? So in that case, I feel like if the Bartholian cyst patient is severe pain, initial they're asking even the best step. Even like pain relief mean we have to open it. If we open it, then there can be if we open it, anyway the pain is released, right? So then after you can do the treatment. Even though it's IND with word catheter, first you have to make the incision, right? The same thing you are doing in the marsupialization, and first in that step the pain is relieved, then after that you can do the treatment. So if you have the marsupialization and recurrent rate is very low, and even though like word catheter, there can be recurrent. It's just only we are putting something inside to drain it. That is it, right? We are not doing anything with the wall. Again, also it can be reaccumulate, right? Because we only keep it for 2 to 4 weeks. Sorry, 4 to 6 weeks only, right? I hope you understand what I'm telling because you have to answer according to the given scenario. For me, I feel like marsupialization is the best option, even in here also, because of the severe pain. Because in other options, in I think day 4 or day 5, the marsupialization option has not in there. They have given the other option, because other possible option is IND with word catheter, right? Because both have the same indications, but they prefer marsupialization, mostly prefer due to the low recurrence rate. In that case, I'm going with marsupialization. This is my answer. I don't know what do you think? Because this makes sense. What do you think, doctors? Because if you have definitive thing, why were they asking initial best step? Best thing is marsupialization, right? What do you think? They have not mentioned anywhere to do the marsupialization. It should be recurrence or it should be abscess. That is something made by made by different doctors, right? If even I was preparing, I know there was a different guidelines, and they have make some rule. Okay, if it is a recurrent case, okay, then only go with marsupialization. That is not true. Okay, because when we consider what is doing in marsupialization, you can understand, because that's the best one to reduce the recurrence rate, right? And the other best option is word catheter. Those two are the best option for the symptomatic Bartholian cyst. Other cases, you can go with conservative management. And IND only use if the definitive management is delayed, right? So we have two definitive management, marsupialization and bird catheter. From those two also, best one is marsupialization due to one single factor, the recurrence rate, right? I hope you understand. So I'm not taking too much time. If you're okay or not, what do you prefer? Tell me your opinion, doctor, because this is a recall class, right? You need to discuss with me. What do you think? Because there's a no proper guideline, doctor. That's what I'm telling. Because we have to forget all the things that we have learned from different groups and everything. Because I also realized after my exam that guideline we can't use, because it's not the Australian one, and the emergency has given something different. So you have to think according to the emergency preference. Like we will hope that they will give proper guidelines for the bath audiences soon, right? Yeah. Yeah. But I still don't know you agreed or not. But this make more sense when we consider with the other options. Remember the definitive management like marsupialization and word catheter both are best. There's one point, marsupialization has a better outcome due to the low recurrence rate, because what we are doing is open it, then you are taking the cyst wall and you're suturing it to the surrounding wall. So there's no space to accumulate it again, right? So everything done and dusted at the first thing, right? Do it, no recurrence. But word catheter also, there can be recurrence rate, some kind of recurrent rate, because you are keeping this the balloon, the word catheter inside only for 4 to 6 weeks. Because in the exam week, I went through the marsupialization and the word catheter. I read some articles, and like the from that I realized again marsupialization is the best one, because there's a other guideline, UK guideline. They are preferring something different. Can't remember properly, but there's something opposite related to the e-medicine question, that we have to follow because this is the only option we have left, right? Yeah. But don't like, just get the theory why we are going with that or not. Anyway, if it is a recurrence, just go with marsupialization. Okay, that's a very proper, like a very clear indication. It's a recurrence phase, right? Yeah, and the abscess also you can go with marsupialization according to the e-medicine question. Next one, patient having a wound on limb with, I think, fracture, limb pulseless distally, limb pulseless distally normal. What do you do first? What do you do first, doctors? Tell me. Mm-hmm. Okay, why reduction? Why reduction? What is the hint they have given to go with reduction? Pulseless, right? Limb pulseless, distally normal. What do you do? Because anyway, limb is pulseless, right? Because of that, there can be some vascular compromise, right? There can be some vascular compromise. In that case, what you should do is you need to reduce the reduction of the fracture, right? Why? Why not antibiotic? Why not antibiotic? What is the famous phrase I was always telling them? You have to first save the limb, right? You have to first save the limb, then you can think about infection. Like if there's a no limb, if the vascular compromise continuously happen, there can be ischemia. If it is ischemia happen, there's a no limb. So if it is no limb, you have to amputate it. Then you don't have anything to prevent from infection, right? So first you have to save the leg, right? That is the funniest way to remember it, right? Yeah. Okay. So if there's a, you can give it a rate. Okay, just simply, if there's a bleeding present, if there's a surgery or like after road accident, you have to follow the ABC pathway, like control the bleeding, give analgesia, right? Then you have to check the neurovascular and the vascular status, right? Then you have to do what? Then you have to after checking the pulse and everything, if there's a problem with the vascular compromise not present, then you can give it an antibiotic. But if the vascular compromise present, you need to do the reduction first. Then you can think about other things, right? That is the way of these fractures, because these questions came in firstly came in this year February, and they are repeating every month, right? Every month you can give it a read. Yeah, here infection is important, antibiotic, but ischemia present, limb death, so more urgent than infection. Perfusion first, infection second. Only if compromise, right? So if a pulse present, you can go with antibiotic first. Pulse absent or cold limb, you have to do the reduction first. This is my note. I made this. I think in March. Yeah, March exam, March recalls. So you need to follow this one. Very simply remember like this. Okay, this is the way you need to remember. Okay, and now tell me. Okay, with the open fracture, what is the other problem that there can be happen other than the neurovascular compromise? What is other complications? Every day when I discuss in this question, I'm telling, uh, not the infections. I'm asking about neurovascular other thing, compartment syndrome, right? It's infection also. Anyway, we have to give the antibiotic. So yes, compartment syndrome, right? Compartment syndrome, because after the reduction and surgery or anything, after that there can be a compartment syndrome, right? Compartment syndrome. In that case, you have to think about that as well. So I have attached some questions. Okay, here two to three questions. You can give it a read. Here's the compartment syndrome question. After the this open after the surgery, I think here after the done the reduction and everything, there was a okay. I'll quickly go through this compartment syndrome, how it present. So usually compartment syndrome present with these five P's: pain, paresthesia, pallor, pulseness, and paralysis, right? Pain is the earliest sign of the compartment syndrome. Without intervention, this condition can lead to the irreversible tissue injury and workman's contracture. So treatment is what remove all the circumstantial resin and plasters, right? The leg is not to be elevated at the reduce the perfusion to the extremity. So adequate analgesia should be given. Prompt contact must be made with the orthopedic team because they need to have the emergency fasciotomy, right? So this is the other one. Not yet they have asked from this compartment syndrome with this open fractures and the surgery after surgery. But soon they can ask about this because usually you need to understand if there's a fracture present, neurovascular compromise, and the compartment syndrome as the main complications. Okay, next one. All age female having fatigue, back pain. What do you want to investigate? So what do you think? Like in this question, actually we are lack of information, but when you consider with these options, what you can think? Yes. You can think about something about multiple myeloma, right? Multiple myeloma. I know it's not enough, but what do you think? Like back pain is one of main feature in this multiple myeloma, right? And the fatigue also can be present, right? But this can be something different, right? Other than that, it can be something different as well because in elderly patient there can be like usual back pain, right? Because they are elderly and they are having like weak bones, and so there can be any it can be mechanical back pain as well. But like when you consider with the options, and because we don't have any red flags here, and they have given other option as serum calcium as well. So consider with the serum protein electrophoresis and those things. Like if it is serum electrophoresis, when we consider and this presentation, you can think about multiple myeloma, right? Because we got a better question, I think, later for the multiple myeloma. This is the one we got in day one. Okay, so actually seems like multiple myeloma, but you need the full step. So what is multiple myeloma? What is multiple myeloma, doctors? So what is multiple myeloma? Okay, quickly I'll explain about the multiple myeloma. So what do you know about multiple myeloma? I know you don't know about the CRAP. So what is CRAP? So what is multiple? It's a malignant proliferation of the plasma cells, right? Inside the bone marrow, right? And it can produce what? M protein, right? M protein. Usually it can see in these older adults, right? So these abnormal cells, like abnormal plasma cells, and these formed M protein, M proteins, right? They can accumulate, right? They can infiltrate the bone marrow, and they can form these monoclonal antibodies, right? They can suppress the blood cell production. Because of that, there can be an anemia, bone destruction, right? Like so many things you can see, right? So C mean what? In the crab, C mean what? Hypercalcemia, right? So then we can see the polyuria, confusion, constipation, dehydration, right? R mean renal impairment. Protein depositions in the kidneys, right? Elevated creatine, we call it Benz-Jones protein, right? Then the anemia, because of anemia, patient can have fatigue, failure, right? Because our case also, the elderly woman has the fatigue. Then B mean bone lesions. We have lytic lesions, right? So because of that, patient have the bone pain, especially the back pain is like a classical feature in the multiple myeloma, right? So other than these features, patients is having the recurrent infections, weight loss, right? There can be spinal cord compressions, right? And the hyperviscosity also can be seen. Due to that, headaches, blurred vision can see. So, okay, how do you identify? How do you investigate? How do you screen for multiple myeloma? What is the best one? What is the best option? What is the best diagnostic method? Okay, what do you know about here? Okay, we'll do this question. A 68-year-old woman presented to the GP with 3 months history of fatigue, back pain, recurrent chest infection. She has no significant medical history and does not take any regular medications. On examination appears pale, pulse rate is 72, BP 120 by 80. Respiratory rate is 16, SpO2 98, temperature 36.7, hemoglobin 98, creatinine 130, urine analysis 2 plus protein. Further urine testing revealed the protein creatinine ratio 350. and albumin creatinine ratio is 50. So which one of the following most appropriate next investigation? Yes, next investigation is serum protein electrophoresis, right? Okay, here. Here, the patient present with the symptoms and laboratory findings suggestive multiple myeloma. The most appropriate next investigation is serum protein electrophoresis, which can detect in the presence of monoclonal protein, this M protein, characteristic of myeloma. The clinical pictures, you know, right? How it presents. Yeah, like that. And if serum protein electrophoresis is positive for a monoclonal protein, further investigations would include the serum free light chain assay, bone marrow biopsy, and skeletal survey or low dose CT to evaluate the lytic bone lesion. This test along with the clinical presentation would help to confirm the diagnosis of the multiple myeloma, right? So initial one is serum electrophoresis, right? Very important. Yeah, here. Serum electrophoresis. Then, if this is confirmed, then you have to do the free light chains and urine protein also you can check, right? Then after that, you can understand if it's a multiple myeloma or not. Okay, if it is M protein absent and normal FLC ratio. FLC mean free light chain. Multiple myeloma unlikely, then you have to investigate for other cases. If it is M protein present and abnormal free light chain ratio present, then multiple myeloma is possible. Then yeah, you can you can treat it if it is possible. So what is the treatment option? So this is other important one for multiple myeloma. You need to understand the treatment. So the treatment is the definitive treatment is what? Autologous stem cell transplantation. That is the treatment, right? But before starting the treatment, you need to do something. And this treatment can be different from the age. For those who are younger than 65 years of age or those who are 65 and 70 with few comorbidities, right? What does that mean? Less than 65 or 65 to 70, 65 to 70 with what? 65 to 70 with less comorbidities. With less comorbidities, you can go with this stem cell transplant treatment. So before doing the stem cell transplant, you need to have the induction treatment cycle, 3 to 6 cycles before the treatment, aiming to achieve the complete or near complete response prior to receive their transplant. So, what are these induction treatment? You have the cytotoxic chemotherapy, and you have to give the steroid, and you have to give immunomodulatory agency. These are the three things that you are using as the these induction therapy. So, what is the combination? Steroid, immunomodulatory therapy, and cytotoxic chemotherapy. These three you have to give 3 to 6 cycles before the treatment. So, let's see. New diagnosed multiple myeloma. So, transplant eligible. So, eligible means what? If the patient is less than 65 or 65 to 70 with minimal comorbidities. So, induction regime typically using combination therapy. You all know what are the three things in combination therapy. Then, after you have to assess at least partial response to achieved or not. If it is yes, then you can do the transplant. Then consider maintenance therapy with novel agents. These novel agents are uh, is this novel immunomodulated? You can use these drugs. Okay. Then, if it is not, if it is at least partial response is not achieved, in that case, you have to do the salvage induction regime, including novel agent, and do the salvage induction again. Then, at least partial response achieved after that, then you can do the autolog transplant. If it is no response achieved, then you have to again do the salvage induction therapy. So, if it is transplant not eligible, that means if the patient is more than 65 uh, with higher comorbidities, then you have to go with the combination then with choice of novel or traditional agents. So we have these immunomodulatory agents, these drugs. I hope this is a very understandable topic. So if it is multiple myeloma, you can go with this one, but you never know, right? Yeah, just need the full stem. Next question. Okay. Cystic fibrosis counseling, CFTR modulators significant improve long-term outcome. So these are not questions actually, doctor. The recallers has given like this. Cystic fibrosis counseling, CFTR modulator significantly improve the long-term outcome. So you need to have idea about this CFTR modulators. So what is this CFTR modulators? What is CFTR modulators? Tell me. Okay, here. So these CFTR modulators are what? In recent years, new type of medications. This is from CFTR module, Cystic Fibrosis Australia guideline. Okay. In recent years, new type of medications known as CFTR modulators has been available in Australia for cystic fibrosis. So these modulators work differently to other medications. This is you all know, right? CFTR modulators we are using for what? For cystic fibrosis, right? Sorry, they work by uh, correcting the malfunctioning protein that cause cystic fibrosis. In doing so, these medications directly address the cause of cystic fibrosis rather than just the symptoms. They are not a cure, but they help the body cell to function more normally. So what is they are doing? They are correcting the malfunctioning protein, right? Then they can increase the proper functions, right? So what does mean is CFTR? So the what is the meaning of CFTR? Chloride channel on epithelial cells, right? So CFTR protein means chloride channel on epithelial cell proteins, right? Usually. Mm-hmm. If the defect cause usually what is happening in cystic fibrosis, there's a thick sticky mucus, right, and the recurrent lung infections, pancreatic insufficiency, right, infertility, bronchiectasis. There's so many things we there's associated with the cystic fibrosis, right? Okay, so then this cystic fibrosis caused by the change in the cystic fibrosis transmembrane conductless regulator gene. This gene controls the production of CFTR protein. What is CFTR protein? I just explained. Chloride channel on epithelial cell. This is a chloride channel on epithelial cell, right? So that is the this protein act on that. Then it here it says surface allow to the movement of chloride in and out. When the CFTR protein is not working properly, the balanced chloride fluid is affected because of that. This is the thing that is happening in cystic fibrosis. So yeah, this means for people who have cystic fibrosis with no CFTR protein or it is not working properly, mucus in various organs become thick and sticky. This can lead to the infection and damage the lung. So most medication for cystic fibrosis focus on treating the symptoms of cystic fibrosis. The CFTR modulator work differently, right? They are rechanging the this malfunctioning protein, right? They aim to restore the function and the faulty CFTR protein, maybe by the CFTR gene, and treat the cause of cystic fibrosis. However, there are approximately 200 gene changes that cause cystic fibrosis, and different gene change can cause a defect in the CFTR protein. So, CFTR modulators that have been developed so far only effective in people with specific gene changes. There are also restrictions on access this modulator, such as age and underlying issues like I have attached like what is happening in this treatment because usually cystic fibrosis we are using the symptomatic management, right? Because they are doing the symptoms, they are approaching symptoms, but in this CFTR modulators we are changing the protein, we are changing the malfunctioning protein to a proper functioning one, right? Okay, that is I couldn't find any question for this safety and modulator one. So because of that, this is the only thing I can give because we don't know what they have asked. I can't remember actually we got later or not, but let's see if we got a later proper question. We'll discuss. Okay. Yeah, this is the safety and modulator therapy. It's a very good one, but you need to make sure they have the specific gene change, right? Otherwise, it's not working. So, stress urinary incontinence, pelvic floor muscle, the first line. I think they are given a stress urinary incontinence scenario and asking the first line treatment. So, first of all, tell me what is urinary incontinence? Sorry, stress urinary incontinence. What is happening in here? Here, what is happening is stress urinary incontinence. Why it is happening? Due to what? Why? Yes. Mm-hmm. Because of the pressure, right? Pressure towards the pelvic floor. It can be pressure to the pelvic floor, and if the weak muscle present, right? Weak muscle of the pelvic floor present because of due to the this stress, there can be some leakage, right? Yeah. So, what are the mechanism what is happening? There can be due to pelvic floor muscle weakness, right? That is the one thing. What else? If there's a urethral splinter problem, right? If it's a splinter problem present, like a small pressure even can cause these stresses incontinence, right? Yeah, mainly due to some abdominal pressure and there's something weakness in muscles or some splinters, it can lead to this leakage. So, what is the first line management? First line management of stress urinary incontinence, female, focus on strength in the pelvic floor muscles and addressing the other contributing factors. Consider referring patient to the continuous nurse, continuous service, or physiotherapist who specialize in continuous issue, facilitate the development, individual management plan. Okay, okay, I'm going to ask. Yes, so you can go with uh, pelvic floor muscle exercises, right? Muscle training is the first line. Okay, I'm going to ask a question. There's an elderly woman, uh, 75 years old, and this patient is present in a stress incontinence, and the patient is having dementia. In that case, what is the best option? What we can do? Patient is having stress incontinence, and patient is having dementia, and patient is very elderly. What you can do? What you can do, doctors? And associate. Okay, most of the time, associate it with what? Okay, okay, sorry, I missed some part. Okay, it's associated with the pelvic prolapse as. Yeah, yeah, yeah. I missed that part. Okay, there's a elderly woman associated with the very minor prolapse. Okay, that is not the severe prolapse. It's like a conservative prolapse. It's not a not in very severe degree, like a very minor prolapse. I think grade one prolapse with the stress urinary incontinence and patient is present in with the dementia and elderly. So, what is the options you can do? You have the pelvic floor muscle, and the you have the what pessary, and you have what are the other options? I can't remember. Yeah, vaginal pessary, right? That's something else. They can give with that prolapse case, right? Prolapse case. I can't remember the option, doctors. So remember, if symptoms is not improved with the first line management or other management, include continuous pessaries and surgical continuous pessaries and surgical management. So yeah, if the patient is remembered, so some patient is elderly, and like even though patient is having some cognitive impairment, right, they can't remember, and they can't keep continuously can't do this exercises, right, because their cognition is not better. In that case, you can go with other options like pessaries and other things, right? Okay. Yes. Next one. Painful postpartum hemorrhoid, topical steroid and local anesthetic ointment. Do you remember we have discussed this one? Painful postpartum hemorrhoid, right? So, what you can do? This topic repeated in April exam. What you can do? Okay, why these hemorrhoids occur in the pregnancy? Hemorrhoids occur more frequency in pregnancy and their reproductive years. During the pregnancy, they are most common in the second and third trimester and caused by the hormonal changes, pressure from the growing uterus, changes in blood flow, and constipation. Women may have internal hemorrhoids prior to pregnancy without any noticeable symptoms, but then develop symptoms when they are pregnant. Hemorrhoids, which occur for the first time in pregnancy, can be managed with simple measures as most of go away. Okay, then they have here, they have mentioned something. Hemorrhoids after the birth, like our case, most women will find their hemorrhoids will resolve after birth. However, occasionally, hemorrhoids may occur for the first time after vaginal birth. Treatment in breastfeeding mother is exactly the same as in pregnancy. So treatment options, what you have, usually best treatment is prevention, a healthy diet, lifestyle modification, those things we can do. But other than that, if it is a very irritating and patient needs some treatment, here you can use this hydrocortisone and prednisolone, corticosteroid reduce the inflammation and itching. You can use lignocaine or local anesthetic cream to reduce the pain and irritation. And you can use these aluminum acetate and allantoin to reduce inflammation, or zinc oxide for the as protective thing. Those are the options you have, and they have given the painful postpartum hemorrhoids, topical steroid, and local anesthetic ointment. This makes sense, right? Mm-hmm. Yes. Due to why? Due to the hormonal changes. Okay. Next question. Tall teenage with pleuritic chest pain. Chest X-ray for spontaneous pneumothorax. This question came in November recall, because here in the November recall we were assuming the patient was a tall teenager, tall thin teenager. But in here, in May exam, they have directly given the tall thin teenager. We can think about what disease we have to think. Spontaneous pneumothorax. Associate in tall thin patient, yes, we have to think about the Marfan syndrome, right? Marfan syndrome. That's a very good approach. So here, sudden onset of unilateral chest pain in the adults and non-rest suggests a primary spontaneous pneumothorax. This is common in teenagers, often tall and thin, can occur without trauma or exertion. Adults with Marfan syndrome at the increased risk of primary spontaneous pneumothorax due to the apical subpleural bleps caused by the abnormal connective tissues. Pneumothorax can occur suddenly at rest with acute unilateral chest pain or shortness of breath. Foreign body typically, because if there's something you have to differentiate from the foreign body aspiration, it's presented with the choking episode, cough and wheezing, and sudden respiratory distress, right? Like if they have given a small child suddenly develop the chest pain, you have to think about the foreign body aspiration, right? Here, but it's a teenager. You can, the tall one, you can think about this Marfan syndrome associated with the spontaneous pneumothorax. So, what do you know about spontaneous pneumothorax management? Okay, this is the spontaneous pneumothorax management. Very important, doctor, because this chart, every step matters, because they have asked from in this part. They have asked a question from this part. Because of that, you need to follow the full flow chart. It's a very important flow chart. Okay, every step matters. Every steps matters. So here is a primary spontaneous pneumothorax confirmed on chest X-ray or CT after chest X-ray. So anyway, if the patient presenting with the pain, you have to give the adequate analgesia and oxygen if only hypoxemic. We are giving oxygen if only hypoxemic, less than 92% percent oxygen, right? Otherwise, we are not giving oxygen, but we need to give analgesia. So then you have to assess the patient if the patient is stable or not. So does the patient have any signs of clinical instability? So what are the features? Systolic blood pressure less than 90, tachycardia, tachypnea, hypoxemia, severe chest pain, or breathlessness. If it is present, that means patient is not stable. If not stable patient present, what you can do? You have to do the pleural intervention with catheter aspiration or intercostal catheter drainage, right? Then after this catheter aspiration or intercostal catheter drainage, you need to consider this patient if the patient is having any of following features requiring further management. Then after this intercostal catheter, you need to check the lung for reinflation. Persistent, if the persistent air leak present or not, the symptoms improved or not. If nothing is present, like no lung inspiration, persistent air leak present or symptoms not improved, in that case you need to go with inpatient admission with the intercostal catheter drainage underwater, the sealed one. Sealed one, right? This is the sealed one. If after the initial catheterization patient is not developed, then you have to follow the underwater seal intercostal catheter drainage, right? So if the patient after the initial intercostal catheter drainage, patient having the lung reinflation and no any air leak and symptoms also improved, in that case you need to, even though you need to observe for another 4 hours, then repeat chest x-ray, then only after the chest x-ray, if you find out the lung is re-expanded and symptoms improved or fully resolved, then only you can think about the discharge plan, right? If it is not, again, you have to go with the underwater seal, intercostal drainage, right? Okay, so here, other side. Okay, patient is not unstable, patient is stable. In that case, you need to observe 4 hours. You need to observe 4 hours, right? Then again, after 4 hours, you have to check the patient's vitals. If patients become unstable, because there can be unstable at any time, because of that, if the again after 4 hours checking these vitals, it's unstable, then you have to follow this pathway, catheter aspiration, this pathway. After 4 hours also, if patient remain clinically stable, what you can do? You have to ensure patient able to seek medical attention if deterioration occurs, or discharge with the advice to represent if symptoms occur. You have to advise the patient if the symptoms occur, you must come to the hospital, and like after advices you can discharge. Then you have to review the chest x-ray after 2 weeks. After 2 weeks, until resolved, refer for respiratory specialist if the pneumothorax does not resolve within 8 weeks or is recurrent. If it is recurrent or not resolving after 8 weeks, you need to refer the patient, right? Yeah, this is the way you have to follow. Very important, okay? So here they are asking, we don't know what they are asking. They have given this kind of questions. So next one, a small, stable, primary, spontaneous pneumothorax. What you can do, the option has given the observation and repeat imaging. So we'll do this question. 35-year-old man presented to the emergency department with 12-hour history of left-sided chest pain. The pain is pleuritic and was on inspiration. He described the tight, diffuse pain across the left chest with a specific point of tenderness in the mid-clavicular region. And the patient came on suddenly while he was having a breakfast. He initially experienced some shortness of breath, and which has now resolved. He has no significant medical history and takes no regular medications. He's particularly anxious about having a heart attack, as his father recently died from one. He has been in emergency department for 1 or 2 hours. On examinations, he appears well. Pulse rate 90, BP 120/60, Respiratory rate is 18, SpO2 98, temperature 36.8, chest examination revealed slightly reduced breath sound on the left side. ECG shows a normal sinus rhythm. Chest X-ray shows 3 centimeter apical pneumothorax on the left side. Which one of the following is the most appropriate management? So here, observation emergency department for 4 hours. Why? Patient currently with the primary spontaneous pneumonia. The recent evidence has shifted the management away from invasive interventions toward the conservative management in the stable patient, regardless of the size of the pneumothorax. So observation in emergency department for 4 hours is appropriate first line management for uncomplicated primary spontaneous pneumothorax in a stable patient, right? Here. Yeah, observation for 4 hours, right? So the same question, except that you need to very importantly follow this chart. Thoroughly, you need to follow this chart, okay? Okay, next one. Okay, we'll take a small break, a small 10-minute break, and we'll continue, right, doctors? 7:32. We'll meet after 10 minutes of break. Okay. Hello, doctors. Hope you all back. Is everyone here, right? Yes. Okay, we'll continue. Okay. So we will discuss here. Next one, bradycardia. Elderly patient on reverse stigmine. Remove reverse stigmine patch immediately. This is also April question, right? Do you remember this question? This is April question. Is a case. Elderly patient is found this should be unconscious, right? That they also were discussed, but we didn't change the stem. Found unconscious on the bathroom floor, unable to provide history. On examination, heart rate 45 beats per minute. Medications include propranolol, reverse stigmine patch. What is the most appropriate initial management? So remove reverse stigmine patch. Okay, so here, what this patient is having. This patient is having symptomatic bradycardia, right? Heart rate 45. Two medication can be contributed. Propanol beta blockers also can cause bradycardia. Reverse stigmine patch. It's a cholinesterase inhibitors that can increase the vagal tone and can cause a bradycardia and syncope, right? So what is the thing we can do the immediately? So patch is the immediate reversible cause, right? So first step, they're asking most appropriate initial step. In that case, first step is to remove the reverse stigmine patch while starting the standard assessment like ABC, CG, monitoring, and IV access. Okay, here this is the bradycardia algorithm. This is a guideline from, I think, something like Ranskog or something guideline, like, can't remember the proper name. I'll show. Australian and New Zealand guideline. Because I will attach the reference. Yeah. Hmm. I think this one. Yes, this one. Okay. The bradyarrhythmia one. Yes, this one, bradyarrhythmia one. I'll attach the reference because this is a very good one to use. Australian Resuscitation Council guideline. Yes. So this is the algorithm. Bradycardia. So if appropriate, given oxygen cannulate vein and record to a lead ECG. So is the adverse first thing first you need to understand this is the proper algorithm. Okay, first thing you have to check if the patient is having adverse signs or not. So what are the adverse signs? These are systolic blood pressure less than 90, heart rate less than 40, ventricular arrhythmias, compromising blood pressure, heart failure. Okay, if it is yes, then you have to give the start atropine 500 mcg IV. If it is not, what you can do, if it is not, you have to check for the risk for asystole. Like see, recent asystole present or morbidity 2 AV block present, complete heart block with broad QRS or ventricular force more than 3 centimeter. Then you have to consider if the risk is present or not. If it is not, then you can just observe. So we'll discuss this side, okay? Adverse signs present. You have to give atropine because here heart rate is dropping, right? So then what you can do then after that, you have to check is a satisfactory response present. If it is yes, then you have to again follow this the risk of asystole present or not. Okay, if it is not a satisfactory response present, or if the risk of asystole present, either risk of asystole or not satisfactory after atropine, what you can do? You have interim measures, so you can give atropine 500 mcv IV, repeat to the maximum of 3 milligram, right? You can repeat to 3 milligram or adrenaline 2 to 10 mcg minutes. Then you can use alternative drugs or transcutaneous placing. So, what are the alternative drugs? You have isoprenaline, you have dopamine, you have aminophylline or glucagon. These are the alternative drugs or transcutaneous spacing. Then you have to think about the expert help and arrange transvenous spacing. That's the final option. But initially, atropine, like you have to follow this path. Okay? This is the one that you need to use for the bradycardia algorithm. Okay, very important, doctors. Right? I hope everything is understandable. Right, but if there's a reversible causes present, you need to remove it, right? As example, it's the offending drug, you have to stop it, right? Like that. Next one, viral illness with positional chest pain and diffuse ST elevation, acute pericarditis. Now tell me, acute pericarditis diagnostic criteria. So what is the diagnostic criteria for acute pericarditis? What is the diagnostic criteria that they have given in TG? Quickly answer. You need to know what is the diagnostic criteria. There are 4 points. Out of 4, 2 should be present, right? Here, acute pericarditis is inflammatory of pericardial syndrome that can be diagnosed by the presence of at least 2 of following criteria, right? Right, doctors? So why you are not remembering this one? It's a very important one. So what are the features? Pericarditic chest pain, pericardial rub or new widespread ST elevation or PR depression on ECG, pericardial effusion new or worsening. So now tell me this chest pain is improved with what and the chest pain is worse with what? Okay, if the patient is lying down, what happened to this chest pain? Is it improved or worse? Yeah. Okay. What about the in supine position or lying down? If the patient is in supine or lying down, in that case, it can worse this pericardial chest pain. But if the patient is leaning forward, in that case, this pericardial chest pain can be improved, right? Very important. These are the points that they are given in the stem. Then you can identify this is a pericarditis, right? Pericarditis. Okay, here. This is a one question. A patient present with chest pain that was, this is a recall, can't remember which one. One of my previous file. A patient present with a chest pain that is worse on lying down and relieved by sitting forward. ECG shows the diffuse T elevation. What is the diagnosis? So pericarditis, right? So tell me, what are the treatments of pericarditis? Tell me, doctors. So, pericarditis should be managed in hospital if the treatable cause is identified or if the patient has one of following factors associated with the poor prognosis. So, what are the following features? High fever more than 38, subacute cause, symptoms developing over several days without a clear acute onset, large pericardial effusion, cardiac tamponade, failure to respond within 7 days to drug therapy. These are the worst in features to the treatment. So, what is the treatment we can use? We can have to use colchicine plus one of the following, either aspirin or ibuprofen, right? The NSAID is usually given to 1 to 2 weeks. The duration guided by the symptom resolution and normalization of. Right? Okay. So now tell me what are the key features of the ECG that you can see in pericarditis? Okay, tell me pericarditis ECG how it present. Okay, diffuse ST elevations. What else? Mm-hmm. Yes. And you can see widespread concave ST elevations, diffuse, right? Then PR depression, right? Throughout the most of the limb leads, 1, 2, 3, AVL, AVF, and precordial leads V2 to V6. So reciprocal ST depression and PR elevation in lead AVR. Sinus tachycardia also common in acute pericarditis due to the pain and no pericardial effusion, right? Here you can see PR depression and ST elevation. And here reciprocal like mirror effect, right? Reciprocal PR elevation and the ST depression. Here mirror mean the opposite side, right? Opposite side. That was reciprocal mean mirror effect, right? Okay, so stages. Stage 1 widespread ST and PR depression with reciprocal changes in AVR occurs during the first 2 weeks. Stage 2 normalization of ST changes, generalized T wave flattening 1 to 3 weeks. Then stage 3 flattened T wave become inverted 3 to several weeks. Then stage 4 ECG return to normal in several weeks onward. Right. So these are the features. I will attach this picture. Oh, sorry, doctors. You can get an idea about it. Okay, right? Okay, if I, yeah. Okay, now tell me this answer for this. 65-year-old woman presented to the emergency department with a 3 days to a first in shortness of breath and sharp chest pain that is worse when lying flat and with a deep breathing. She has been unwell with flu-like symptoms for the past week. She has no significant medical history and take no regular medications. So on examination, she appears mildly distressed. Her pulse rate is 95, BP 125 by 80. SPT rate 22, SpO2 96, temperature 37.8, jugular vein pressure elevated at 4 centimeters. Then chest examination revealed by basal palpitations. Heart sounds are normal with no rub audible. An electrocardiogram shows the diffuse T elevations and PR depression with reciprocal ST depression in AVR. A chest X-ray shows an increased cardiothoracic ratio of 0.6 with a globular cardiac appearance. So, which one of the following is most appropriate initial treatment? Now, tell me the treatment. Type in the chat. Yes. Okay, here you need to understand ibuprofen and colchicine is the most appropriate initial treatment and say the cornerstones of treatment of acute pericarditis because there's a inflammation, right? Providing both symptomatic relief and treating the underlying inflammation. The additions of colchicine has shown the randomized trial rate with the symptoms and duration of the recurrence rate. So ibuprofen and colchicine, right? Remember this one. Yes. Okay, so next one. Most important teratogens causing neurodevelopmental impairment is alcohol. Don't argue. Remember, this is the most teratogenic one is the alcohol because this question gave in April exam. Right, like this, the last set most likely from April recalls. Okay, from April recalls. So you all know alcohol. Why alcohol? What are the What are the features that you can see in alcohol effect uh, during the pregnancy? What patient can see? What can happen to child? What other things can happen to the child if mom is using alcohol? Yes, alcohol, fetal alcohol spectrum disorder, right? So growth, what is happening? Intrauterine growth restriction, low birth weight, poor postnatal growth, facial features like smooth philtrum, thin upper lip, short palpebral fissures. Can see, right? I'll show a picture. Central nervous system, developmental delay, and the intellectual disabilities, poor memory and learning, behavioral problem like ADHD, and the microcephaly. Other possible defects are congenital heart defects like VSD, skeletal abnormals. Here we can see that is a typical presentation how the child is present. Small palpebral fissures, low nasal bridge, upturned nose, thin vermilion border, undeveloped jaw, then epicanthal fold, flat mid face, smooth philtrum. Yes, smooth philtrum, microcephaly. These are the features that can see. But during the growth, there can be indifferent growth restriction and low birth weight can see. Okay, if it is from nicotine or smoking, low birth weight, placental problems, and preterm births, not a major structural heterogeneity compared to the alcohol, heroin, neonatal abstinence syndrome, growth restriction, and doesn't cause major congenital malformation. But alcohol is very teratogenic and we should avoid. You can give it a read this question. There's a question for this one. Yeah, so alcohol. Remember, very important. Okay, very important. This is a recall from April. Okay, next one. Next one, hypercalcemia with constipation and polyuria, primary hyperparathyroidism. Okay, so what do you know about this hypercalcemia? So hypercalcemia, usually how this serum calcium is regulated by. We have parathyroid hormone, vitamin D, and bone turnover, right? So parathyroid hormone action is increase calcium reabsorption from kidney, that increase the reabsorption, and increase bone resorption. Right, then increase with vitamin D activation, increase gut calcium absorption, altogether raise the serum calcium, right? Then, what is the pathophysiology of hypercalcemia? Hypercalcemia happen when the calcium enter the blood faster than expected, right? The higher level. So this can occur through increased bone resorption, right? And the increased intestinal absorption and reduce renal excretion. Excretion reduce, bone resorption increased, and the intestinal absorption also increased, right? So here. So what is the mechanism? We have primary hyperparathyroidism for the hypercalcemia. That is the most common case of the hyperparathyroidism. So what are the other causes that can cause, that can cause hypercalcemia? Tell me, doctor, what are the other causes that can cause hypercalcemia? Give me examples other than primary hyperparathyroidism. Yeah, so many things, right? We have vitamin D and A excessive mobilization, thyrotoxicosis, adrenal insufficiency, neoplastic related diseases, right? Sarcoidosis, suicide diuretics, right? Paget disease, like so many causes, right? Yeah. Okay. Yes, so we'll discuss about what is happening in primary hyperparathyroidism. So usually in primary hyperparathyroidism, what is happening is mostly due to this parathyroid adenoma, right? Due to this parathyroid adenoma, there is a excessive parathyroid hormone. Why? Because this parathyroid adenoma can produce the parathyroid hormones, right? So, because of that, increased osteoclast activity, in that case, bone breakdown is increased. Then the increased renal calcium reabsorption, increase vitamin D activation. Then, because of that, this vitamin D is reabsorbed from the gut, right? Then, overall result, chronic mild to moderate hypercalcemia can be seen. Parathyroid is high or inappropriately normal, right? Because due to this adenoma. Right, so other than that, we have malignant-associated hypercalcemia. Like I'm not going to explain everything because our topic, the recaller, has given about primary hyperparathyroidism. Right, so this is what happening in primary hyperparathyroidism. And due to some adenoma, this question has came on not as a proper one. They have asked in day one of April exam as. Do you remember they have given a topic as primary hyperparathyroidism? Right, I have explained everything, right? Yeah. Okay, here, yes. Can give it a read. This is for everything for hypercalcemia. Everything for hypercalcemia. This is hypercalcemia associated with cancer. I have attached this one because in I think in March they have asked from this topic, right? Hypercalcemia associated with the cancer. Yes. Okay, I'll show something. Hyperparathyroidism, the management. Okay, the treatment. Here, primary hyperparathyroidism is most commonly caused by a single parathyroid adenoma. Definitive therapy is the surgery, which is cures 95% cases and have low morbidity. And watch and wait we are using in which cases instead of the surgery in patients who are more than 50 years or older and have a total serum calcium concentration corrected for albumin lower than 2.9, a normal kidney function, no nephrolithiasis or nephrocalcinosis, bone mineral density T score higher than 2.5, no symptoms, right? In that case, we can use watch and wait because I will attach this part because of the treatment and everything, right? If you have the April file, just check. I think day one we have discussed this one as well. Okay. So is everything understandable? This is for extra things, okay? Extra things, because they can ask. Give it a read, okay? Give it a read. I have highlighted each and every important points in here. Okay, next question. Septic obstructed uteric stone, urgent decompression of collecting system. Do you remember this question? I have explained multiple times in March and I think February, March, and April. Can't remember the February, but this question came in March and April both. Okay, so we'll discuss some question. Okay, 35-year-old man presented the emergency department with 12-hour history of severe colicky, left-sided abdominal pain radiating to from the loin to his groin, feels nauseated and have vomited once. He has a medical history of right nephrectomy for a Wilms tumor at age of 2. He takes no regular medications. On examination, he appears unwell. A minute. Yeah, sorry for that. He appears unwell and dehydrated. His pulse rate is 108, BP 100 by 80, respiratory rate is 20, SpO2 98%, and the temperature 38. Abdomen is soft with left loin tenderness. So, urine analysis shows a pH 7.5, red blood cells +2, leukocyte +2, and nitrate positive. Serum creatinine 90. A CT urogram shows the 2.4 centimeter radio opaque stones in the pelvic ureteric junction, and hydronephrosis. Intravenous fluid and non-steroidal anti-inflammatory medication have been commenced. Which one of the following appropriate next step in management? So why ureteric stent? Why we are using a stent here? Why we are using stent here? Why we are not removing the stone first? Why? What is the reason? Okay, what else? Is this the only one? The solitary kidney is the only one. What are the indication for the urgent decompression? No use stent. What are the other indications? Yeah, solitary kidney is the indication. What is happening to this patient? Leukocytes +2, RBC +2, temperature 38, and hydronephrosis. Is it only that? What about patient is having systemic infection, right? Fever, right? And urine analysis shows the pH 7.5. Okay, here. Urgent decompression in patient with kidney stones is required if the patient has solitary kidney, bilateral stones, intractable pain or vomiting, acute renal failure with electrolyte dearrangement or uremic symptoms, fever or features of concern in early infection. Even though you are not remembering about the solitary kidney or hydronephrosis, just fever is enough. And if there's a visible stone is present, with this severe quality pain with the urinary stone, then you can go with decompression, right? Very important topic, doctors. Right, if this case patient presents with obstructing ureteric stones in a solitary kidney with the signs of infection and therefore has a multiple indication for urgent intervention, the alkaline urine pH suggests a non-uric acid stone. The most present priority of to deal with the sepsis, right? In other words, decompression of the obstructed renal tract must take the priority over removal of the stone. By first, you have to treat the infection, right? You have to do the decompression. Then you can treat the stone later. So here, management, this is from the emergency question. Obstructed stone with infection, fever, leukocyte, hydronephrosis, obstructing stone, sometimes solitary kidney. The management is urgent decompression of urinary tract, right? You need to do urgently something, right? You need to decompress it, right? Release the blockage. Then later you can decide what is the definitive management, but initially you need to do the decompression. Preferred one is ureteric stent insertion, but if stent insertion is not available, you can use percutaneous nephrostomy as a alternative one, right? Yeah. So the key rule is decompress first, remove stone later, right? Yes. Is everything understandable, doctors? Read this question again and again. This is a very important part. Stones with the infection, right? Okay, I have attached another question as well. Yeah, so I think, yeah. Oh, no, this is something different. Okay, sorry, doctors. Yeah, here. So COPD exacerbation with hypercapnic respiratory failure. The Ricola has given NIV with control oxygen therapy. So what do you know about the COPD oxygen therapy? What do you know about COPD oxygen therapy? Tell me, doctors. Okay, here, let's discuss this question. Okay, 65-year-old man presented to the emergency department 3-day history of bursting shortness of breath and productive cough. He has a medical history of COPD. His regular medications include salbutamol inhaler, fluticasone salmeterol inhaler, and tiotropium inhaler. He's an ex-smoker with 40 pack year smoking history. On examination, he appears fatigued but responsive. His pulse rate is 110, BP 100 by 60, respiratory rate is 22, SpO2 86, Temperature 36.8. Speaking in short sentences. There is a widespread expiration, expiratory wheeze and crackles in the right mid-zone of the lower zone. Metabolic flap is present. So pH 7.28, PaO2 60, PaCO2 65, HCO3 is 26. So they are asking which one of the following is most appropriate next step in management, right? Okay, so we have options. Continuous positive air pressure, nasal high flow oxygen, chest drain, intubation and ventilation. Uh, Bilevel positive airway pressure. What do you think? What do you think, doctors? Okay, here, what do you think about the answer? Okay, in COPD patients, what is the normal level of oxygen? What is the normal oxygen level for COPD patient? What is the normal level? 88 to 92. When we should start the oxygen therapy? If it is less than 88 only, we are starting the oxygen therapy, right? That's the one of most important point you need to remember. Not with other patients in COPD, the oxygen saturation normal limit is low, right? Lower than other cases. So let's discuss this question. Yeah, that should be low flow, right? Yes. So here, the answer is what? Answer is what? Bilateral posterior pressure. Okay, let's discuss why. The patient present with acute exacerbation of COPD complicated by type 2 respiratory failure, hypoxemia and hypercapnia. The arterial blood gas shows the uncompensated respiratory acidosis with elevated PaCO2. So, normal bicarbonate and low pH. So, bilateral positive airway pressure or BiPAP, BPAP is the most appropriate next step. So it's provided two levels of pressure, support higher during the inspiration and lower during expiration, which reduce the work of breathing and improve the ventilation. Multiple studies shows the BPAP reduce the mortality and intubation rates in COPD patient with hypercapnic respiratory failures. Right? Yes. So what we can use. So let's see our question. Our question, what it is. Okay, 1 minute. So when we use CPAP, continuous positive airway pressure, provide only a single pressure level, which, while helpful for oxygenation by keeping airway open, does not provide the same ventilatory support as BiPAP. The dual pressure level in BiPAP make it more comfortable and effective for COPD patients. So they are recommending BiPAP is best. So, nasal high flow oxygen would improve oxygenation but would not address the ventilatory failure. Additionally, high flow oxygen could be dangerous in the COPD patients, right? Yeah, high flow is toxic for COPD patients. Intubation and ventilation would be indicated if the patient deteriorates despite the BPAP, develop inspiratory arrest, and cannot be tolerated non-invasive ventilation. It is not the first line therapy. So yeah, yeah, okay. Okay, let's go to our question. Okay, sorry. Let's have a question. Yes, here, yeah. COPD exacerbation is hypercapnic. Yes. So COPD exacerbation with hypercapnic respiratory failure. So what you can give? I can give, but non-invasive ventilation with BiPAP method, right? BiPAP we can use, right, doctors? So, so that is the answer, right? Yeah, so where we are using CPAP. We can use CPAP for obstructive sleep apnea, right? and the pulmonary edema, right? So in the COPD, we prefer BiPAP, right? BiPAP, which has, yeah, and it should not the high flow, right? Not high flow, because it can be toxic for the COPD patients, right? Yeah, everything is, I think, it's understandable, right? So non-invasive ventilation, BiPAP, right? We have to use, remember BiPAP. Okay, so we can go with this option. Next question, Australian cervical screen, HPV based screening every 5 years. We don't know the question, but we got the questions, different types of question from here later days. But I will explain like cervical screening. So cervical screening, if you are age 25 to 74 and you have in a service, important to keep update with the cervical screen, right? So we're starting from 25. Okay, so yeah, who should be screened? You are eligible for cervical screen if you are 25 to 74 years old, you have a cervix and you have ever been sexually active, right? In this traits are fulfilled, you are eligible to do the screening, right? It's important to know that cervical screening is relevant regardless of sexual orientation or gender identity. Regardless of sexual orientation or gender identity, whether the gay, lesbian, or bisexual, transgender, or straight, it is recommended whether or not someone has received the HPV vaccination. Screening is still important even if a person is no longer sexually active, but they have ever been sexually active, like have ever been sexually active, has gone through the menopause, or have ever had a one sexual partner. It doesn't matter, but at least one time they should be sexually active, even though it's not like currently not active. It's okay. But still, we need to do the screening, right? So this is the screen program, and we have this chart. So I'll explain once we get a questions, right? Because in the future we will get most of the questions from different areas, then it will make more sense. Otherwise just I can read this, but when we get a questions only, you will understand, you will remember how you should follow this. Yes. Okay, doctor. So we'll discuss. Okay, we got, I think, three types of question from this chart. Don't worry, I will explain once I get the question. Next one, central retinal artery occlusion and artery occlusion. Treat as the Ricola has given, treat as acute ischemic stroke equivalent, right? Now we are using the central retinal artery occlusion, and it has a stroke management pathway. We have to use it, right? First of all, tell me how the CRAO present. So sudden painless severe unilateral vision loss. Vision often reduced to count in fingers or fingers. A relative afferent pupillary defects, or we call it RAPD, present, no eye pain or no redness. So what you can see? Sudden painless severe unilateral vision loss, right? Yes. So what you can see in fundus, this is a very important one. What is the most important one? Cherry red spot. Cherry red spot is a very important point for this CRAO. Very important. Okay, if you see a cherry red spot, think about CRAO. So what you can see in funduscopy, diffuse retinal whitening, edema, right? Diffuse retinal widening, swollen retina became opaque and pale on funduscopy, cherry red spot at the macula, intact choroidal supply, narrowed attenuated arterioles. So risk factors: atherosclerosis, embolic disease, atrial fibrillation, giant cell arteritis, diabetes, hypertension, smoking, because it can be associated with the giant cell arteritis as well. Okay, here. Yeah, this is all recall from November I have attached just for like sake of knowing to differentiate the CRAO with CRVO. But don't worry, later we got the CRVO full question. In that case, I will explain. And that in the day one, I have just go through like how it present. So how this CRVO present? Like what is the way of fundoscopic presentation of this CRVO? Tell me, doctors, what you can see in fundoscopy. How it presents CRVO in fundoscopy. How? Blood and thunder, right? Yeah, blood and thunder or tomato splash. And can you see blood and thunder? We call it tomato splash, right? Tomato splash. Yes. So don't worry, we'll discuss this one in the future topic in our recall class. Today topic is CRA. Okay, so let's discuss the management here. So patient with sudden painless monocular vision loss with the afferent pupillary defect. So a typical CRA finding present on fundoscopy if it is there. Let's see. Then urgently check for GCA in patient more than 50 years old, 50 years old using CRP and ESR because you need to exclude, right? Because giant cell arteritis also can be present with that. So you have to exclude it first. And yes, you have to check ESR and CRP and more than usually associated with the patient 50. Right, and if the patient is having headache, jaw claudication, scalp tenderness, and systemic symptoms, is GSA likely diagnosed? No, if it is not, what you can do, urgently transfer to emergency room affiliated with the stroke center, then treat CRAO as acute ischemic stroke, right? Acute ischemic stroke. So do not perform conservative measures such as ocular massage, anterior chamber paracentesis, like that. So obtain ophthalmologic evaluation and neurological exam and non-contrast CT of the head, right? This is how you should follow. So then after consider IV thrombolysis unless there are contraindication per standard acute ischemic stroke protocol like that. Okay, now tell me how you should. Now you have to tell me step wise. Okay, if you are suspecting a stroke, what is the first thing you need to do? Okay, patient is in the hospital. First thing what you need to do? Tell me, doctors. What is it? Yes, non-contrast CT. Very important. Never forget that. Okay, what is the reason of doing non-contrast CT? What is the reason of doing it? What is the reason? Why initially we are doing non-contrast CT? Yes, to rule out this. Yes, brain hemorrhages, right? Yes, yes. Okay, we'll discuss how. Patient presented with suspected stroke or TIA. What you can do at the moment? Okay, here. So, so presentation we all know. So, are the symptoms ongoing at the time of presentation? At the moment, is symptom present or not? This is from the TG. This is stroke management. If it is yes, this is an emergency. The ongoing symptoms present. This is an emergency. Urgently transfer patients to the hospital via ambulance for assessment. Transfer to hospital with the acute stroke unit care capable of delivering the reperfusion therapy. So what urgent assessment needed including imaging and testing to investigate the stroke. Right. So here, uh, at the moment, not symptoms are not presenting. Urgent imaging and investigation needed to assess likelihood of stroke. And assessment is more urgent if symptoms have resolved in the last 48 hours or if there have been multiple episodes in the last 7 days. Okay, here because then you can think about TIA, right? If it is because you know TIA and stroke, we have two main things, right? So here, if it is a stroke is suspected after the initial imaging, non-contrast CT. If still suspected, if it is yes, then you have to treat the acute stroke. So you can use the reperfusion therapy, right? Reperfusion therapy, I'll explain. If a stroke is suspected, no, then you have to think about other condition that is like with the stroke, right? So we have the list of stroke mimics, right? Yes. Okay, I'll explain from the teacher because here they are not like very much giving the explained one. Okay, which point you have got confused, doctors? Dr. Grace, I think you have learned this stroke topic multiple times. So what is the confusion? What is the confusion you have? Okay. Okay. Key principles of stroke management, early recognition of stroke symptoms. So, okay, I'll show the stroke symptoms as well. Okay, that's the stroke symptoms. It's a place. Okay. Okay, here stroke present as a focal neurological deficit like hemiparasis, language dysfunction, vision loss, and the brainstem signs that has comes on abruptly. Evaluate the patient in the hospital urgently because the timing of treatment is pretty critical, right? Transfer patient via the ambulance and close emergency department. An acute stroke or transient ischemic attack is a medical emergency, right? Yeah, doctor, what is the point you missed, Dr. Grace? What is the point you missed? Okay, this is the symptom. Okay, then what you should do? Next thing, you have to uh, transfer patient to the emergency medical interventions, right? So then you have to do the immediate neurological assessment. Here. So initial assessment of the diagnosis suspected acute stroke or TIA. So even though TIA or anything, a stroke, anything, first you have to do is what? You have to do the what initial assessment. So diagnosis of a stroke and TIA is predominantly based on the clinical assessment and urgently refer patient with ongoing symptoms to hospital. Yeah, those things. Then for the rapid expert evaluation, 1 minute, immediate treatment and early reconsideration to secondary prevention. Yeah, here the urgent brain imaging is a key assessing of the suspected stroke or TIA-5. You have to do the non-contrast one to exclude the hemorrhage, right? Very important. That's the most important thing in all patients presenting with suspected stroke or TIA, right? Very important. Then, what do you know about this reperfusion therapy? What do you know about this reperfusion therapy? Okay, this is the reperfusion therapy. So this is not the topic, but I'll quickly explain because like stroke is a very important topic. So here we have two things, right? Intravenous thrombolysis and endovascular thrombectomy. So this is so acute ischemic stroke, right? Doctors, just give me 2 minutes, okay? Sorry, give me 2. Sorry for that, doctors. I got a important call. Yeah. because we are planning. Yesterday, I told you my mom's varicose vein, the sclerotherapy. Yeah, today the consultant has like made the appointment for the tomorrow. Yeah, that's what. Yeah, okay, that's fine. I got a call because I couldn't miss that. Yeah, okay, fine. Next one, intravenous thrombolysis and endovascular thrombolectomy. These are the two treatment for perfusion therapy. Okay, if the patient is present in, yeah, she's totally doing okay, but we have to do the treatment, right? Because the varicose vein we should not keep. It's a small thing, right? Small, we have to do it. That's what. Otherwise, it's can be like there can be so many complications later if you are not treating, right? So we decided to make a sclerotherapy. Because our surgeon recommended it because yeah, his choice. Okay, so what you can see, this topic is very important. The stroke. Okay, so initially non-contrast CT. Then if you find out it's a stroke, then what you can do for the stroke, you have the reperfusion therapy. And here, a stroke onset within 4.5 hours if the patient present, you can go with intravenous thrombolysis, right? Intravenous thrombolysis, all patient unless contraindicated. So when we are using endovascular thrombectomy, so all patient with large visual occlusion, we can use if the patient is having large vessel occlusion, it's intravenous thrombolysis is not enough. Like if we see a large vessel occlusion, within 6 hours, you can decide the treatment as endovascular thrombectomy, right? Okay, for the intravenous thrombolysis, after 4.5 to 9 hours, between 4.5 to 9 hours, then patient with salvageable brain tissues evident on the perfusion imaging, then if it is present, then you can go. After 9 hours till 24 hours, consider on case by case with the specialist input. But if they are present in within onset of stroke till 4.5 hours, you can give this intravenous thrombolysis therapy unless contraindicated. So, endovascular surgeries, endovascular thrombectomy, all patients with large vessel occlusion from onset to 6 hours. Then, after all patients with large vessel occlusion and salvageable brain tissue evident on the perfusion imaging, from 6 hours to 24 hours, still can we use endovascular thrombectomy, right? It's like after this initial 6 hours or after this 4.5, you have to decide. Yeah, you have to decide what you should do. Okay. But if it's a large set one, you can go with endovascular thrombectomy. Right? So this is the treatment options you have. Sorry, treatment options you have. Okay. So yeah. I hope everything is understandable. I know this is kind of extra, but you need to understand it, right? You all know what are the contraindications for thrombolytic therapy because it's not a very hard topic. It's like every day we are discussing, right? I will attach this part as well, the contraindications usually. What are those? Yeah. Then after only we are deciding the treatment, like other treatment. These are the initial acute management. After we have to treat this patient with the antiplatelet therapy, right? After antiplatelet therapy, then you can use what? Then you can do the secondary prevention. You can add the statin therapy or hypertension therapy. Like according to the patient's comorbidities, you have to decide the other secondary treatment, right? Yeah. That's like a summary for here. Like here, secondary prevention, lifestyle general measures, antiplatelet therapy, oral anticoagulation, and blood pressure lowering therapy, cholesterol lowering therapy. These are the things. At acute cause, you have to go reperfusion therapy. I just explained thrombolysis or endovascular thrombectomy, antiplatelet therapy. If patient need neurosurgery and the supportive care, right? Okay, so that's all. Okay, doctors. Let's move to the next question. Yes. Is it understandable? Dr. Grace, do you have still any doubt? Okay, next one. Next one, dengue fever management. The options as given: careful, fluid monitoring, and avoid overload. No, right? Okay. So if you have any doubt, just ask. Okay. Even after during the class, also, if you have any doubt, just text me. I'll help. So we'll discuss about dengue fever because these are just topics, right? So we all know for the dengue fever, we have to carefully manage the fluid. Okay. Let's quickly discuss about what they have mentioned in the TG about dengue. Dengue is a viral infection transmitted to human through the mosquito bites. We all know that, right? We have primary vectors is Aedes aegypti. In Australia, dengue is among most frequently diagnosed imported infections among unwell returned travelers, right? So, approximately 70% of the infection occurs in Asian Pacific region, which is common travel destination for Australians. So, dengue is endemic in more than 100 countries, tropical and subtropical regions in Southeast Asia. So, no need to read that part. So, how this dengue is presented? Dengue is a self-limiting acute febrile illness with non-specific manifestation. Among people infected with the dengue virus, approximately 60 to 80 are asymptomatic or have um, one minute, have subclinical infection. When symptoms occur, they usually begin 4 to 10 days after exposure and last 2 to 7 days. Remember, after 4 to 10 days, okay, begins after 4 to 10 days. These are very important for the infections. What are the incubation period? How long symptoms present? These are very important. And after exposure lasts for 2 to 7 days. Common symptoms include fever, severe headache, retroorbital pain, myalgia, arthralgia, lethargy, nausea, vomiting, and macular rash. So, retroorbital pain is a very important point. Okay, dengue is a self-limiting acute febrile illness with non-specific manifestation. Here. Okay, so but we have something called severe dengue. Most important one of most important because severe dengue with the hemorrhagic rash and everything. That's a very severe case. So severe dengue occurs in 5% of dengue infections, more common in patients older than 65 years, patients with significant comorbidities, and the pregnant patients, right? So secondary dengue occurs in patients who are infected for a second time with a different dengue serotype. Patients with secondary dengue are at a greater risk of severe dengue, right? Severe dengue can be life-threatening and characteristic by plasma leakage that can lead to the shock and hemorrhage, right? We call it hemorrhagic dengue fever, right? The plasma leakage and the hemorrhages, right? The dengue becomes severe. Symptoms more occurs around 4 to 6 days of the illness, coincident with the patient becoming afebrile. Typical red flags are these. So, what are the red flags? Abdominal pain or tenderness, persistent vomiting, mucosal bleeding, severe lethargy or restlessness, fluid accumulation in peripheral edema, pleural effusion, ascites can be seen, liver enlargement, rise in hematocrit and liver transaminase, fall in albumin and platelet count. Very important. Remember these red flags, right? Then the next one, how you should diagnose the dengue. Okay, perform dengue testing on febrile return travelers, particularly those who have rash or other suggestive symptoms. Now, within first 5 to 7 days of illness, dengue can be diagnosed by blood sample analysis for non-structural protein NS1 antigen or PCR testing. So, how long? First 5 to 7 days of illness. Very important. Seroconversion occurs from about 5 of illness, day 5 of illness, right? So dengue serology should be interpreted cautiously because false positive result can occur due to antibody cross-reactivity. False negative result may be seen in the early cases of dengue. Repeat serology after at least 7 days of diagnosis recent infection because earlier earlier you can diagnose it with this NS1 antigen or PCR, right? Because seroconversion usually after day 5 of the illness. Very important, doctor. Please remember, write down these points, okay? Because they are given in TG. Okay. In case of secondary dengue, interpretation of serology can be difficult, right? So if you want like if the serology test is false negative in earlier, you should, if you're still suspecting dengue, you should repeat it after 7 days, right? Very important. Then perform full blood count and liver function test. You need to take the platelet count, right? And thrombocytopenia, leukopenia, liver transaminitis, commonly seen. Dengue is a notifiable. It's a notifiable disease in Australia. Report all confirmed and preferable case the local public health authority. So the management. Okay. No specific treatment for dengue is available. However, supportive management is important. Patients should ensure adequate fluid intake. This is the part they have asked in the exam in this recall, right? So adequate fluid management, right? Because you have to prevent from fluid overload, right? Paracetamol can be used to treat the pain. Aspirin and non-steroid anti-inflammatory medication should be avoided in patients with suspected or proven dengue because the risk of bleeding complications, right? Next one, patient can be managed in the outpatient setting. However, hospitalization recommended for patient with age more than 65 have significant comorbidities or pregnant because they are high risk patient for severe dengue. We have already discussed, right? Okay, then perform daily clinical review during the critical phase of illness, day 3 to 7, including blood tests to monitor hematocrit, platelet count, and liver function. Okay. If the red flag develop any cases, that small rectangular part, they have given the red flag, we just discussed. They should be referred to a specialist or admit to the hospital. Refer patient with the severe dengue to a hospital for supportive care. Fluid replacement may be life-saving in severe dengue. However, it should be stopped when plasma leak can resolve to avoid fluid overload, right? The prevention approach to preventing dengue include the vaccination and reducing the risk of mosquito bite. So simple measures, what are these? Applying effective insect repellents using the other insecticide. Wearing light colored long trousers and long sleeved shirt. Avoiding perfume and aftershave. Okay, so these are the things. I hope everything is understandable for dengue. Remember the red flags, how to diagnose, and how is the management is ongoing, and who are the higher risk people, right? I hope everything is clear. Next question. Let's see how many pages we have. Okay, a few more pages, right? This is some doctors have already went right. Yeah, that's what I was asking. Okay, so encephalitis with thalamic MRI changes after campaign in Victoria. They have given the record has given uh, Murray Valley encephalitis. So Murray Valley encephalitis, this is the disease. So I have got a question from eMedicine as well, and this is the guideline we can use. I'll show. So what is this Murray? I don't know. I'm pronouncing it correct. The Murray Valley or Murray Valley. I don't know. Murray Valley encephalitis. So what do you know about this one? This is a one of new disease they have given here. So what is Murray Valley encephalitis? So it's a rare but potentially serious infection of the central nervous system caused by this Murray Valley encephalitis virus. Right? So cases of these virus were reported in Victoria and other southeastern Australia states in early 2023. These were the first case in Victoria since 1974. This is transmitted to human by infected mosquitoes. The most infections are asymptomatic and less than 1% of infection people can develop the clinical disease. Considering treating for MVE and other mosquito-borne diseases in patients with compatible illness, if acute infection is suspected, convalescent blood test 2 to 4 weeks after symptoms onset is essential as the antibodies may be not be detectable at the symptom onset. Like most of the time, antibody conformation later, right? After the seroconversion, right? So treatment is supportive. The best prevention is protect against mosquito bites. You can use the repellents, right? Yes, and MV is an urgent notifiable disease, right? Remember these. These are the important things you need to understand. I will attach this one because I have attached the. Then you need to know um, what are the school exclusion criteria. So there's a no exclusion is required. Okay, remember, no. So no exclusion is required. Remember. Okay, so you can give it a read. So what are the clinical features? Most people infected with the MV virus do not have symptoms with the less than 1% developing clinical illness, about 1 in 800 infected people. So illness usually start with headache, fever, nausea, vomiting and myalgia. People with severe infection may develop drowsiness, confusion, or meningism with a severe headache, neck stiffness, and photophobia. Please give it a read, okay? Because this is a new thing. And you know the funny fact in about May exam, they have given some new different topics, okay, like this. I'll show in the future classes, okay? Yeah, for some people, severe illness may be lead to the long-term neurological complications or death. So yeah. Mhm. Okay, so we just do the just only one emergency question. So here also they have asked to diagnose it. Like most of the new cases, they are giving diagnosis. Like they are giving a scenario and ask what is this. Here, 24-year-old man presented the emergency department 3 days of severe headache, neck stiffness, and confusion. He returned 1 week ago from working on a cattle station in Northern Territory during the wet season. He has no significant medical history and take no regular medications. On examination, he appears unwell. Pulse rate is 110, blood pressure 130 by 85, respiratory rate is 22, SpO2 98, the temperature 38.9. He is drowsy but rousable. There is a marked neck stiffness and photophobia. Neurological examination revealed no focal deficit. Brain MRI shows the bilateral thalamic changes. Murray Valley encephalitis virus PCR from cerebrospinal fluid returned positive. Which one of the following cerebrospinal fluid finding is most likely to be present? Okay, it's a good question. Okay, we'll discuss the answer. So, lymphocytic fluocytosis. So, this case presented with the confirmed case of Murray Valley encephalitis virus infection, with the typical features including recent travel to the endemic area during the wet season, progressive neurological symptoms, and characteristic of bilateral thalamic changes on imaging. So, lymphocytic fluocytosis is the characteristic CSF finding in viral encephalitis, including Murray Valley encephalitis. The CSF typically shows a mild to moderate increase of lymphocyte, usually 10 to 300, right? With the normal glucose level and mildly elevated protein. I know this is a new topic. Just make a small note for this one, okay? Yeah, I'll show. Let's see what they have given other than that. Mm, they have not given anything about image in here. Yeah. But remember, there's a thalamic. Um, what they have given? Thalamic involvement, right? Yes. If bilateral thalamic changes. Here also question they have given. Encephalitis with thalamic MRI changes after camping in Victoria. So Murray Valley encephalitis, right? They have asked to diagnose it. Here this is the one they have given in e-medicine. So give it a read, okay? I know this is a new topic, but you can make a small short note for this one. Next one, immunocompromised patient with diffuse vesicular rash, disseminated varicella VSV needing IV aceclopine. So, what is this? Herpes zoster, right? So, yeah. So, what do you know about this herpes zoster or shingles? What do you know about that? What do you know about this varicella zoster virus? Okay, what is this shingles? So shingles or herpes zoster is a caused by reactivation of varicella zoster virus, right? It's a uncommon in childhood and it is increased with the age. Shingles used more frequently in patients with immunocompromised who are more likely to develop the disseminated disease, right? So shingles is usually self-limiting infection lasting 10 to 15 days, right? It's characteristic by painful rash that present with blisters in the dermatomal distribution on erythematous base, right? The blisters erupt over a week and then heal over 2 weeks. So how it is present? Yeah, here can you see? I'll show a better picture. Can you see blisters? Here, can you see dermatomal dermatomal distribution? You can see here. It's a rash is a blisters, right? Blisters, rash, a very painful rash, right? Very painful rash. Yeah, like that. Okay, I'll attach this one and the proper picture as well. Okay, then you can get an idea. Next question. Okay, here, so you need to understand the treatment because you need to know when to give oral treatment and when to give IV treatment. Very important, okay? Listen very carefully so you know how it present, the presentation. A minute, just attach picture here. Otherwise, I'll forget it. Okay, here. So, how it present is a self-limiting infection lasting 10 to 15 days. Usually 2 weeks is present in characteristic by painful rash that present with the blisters in a dermatomal distribution. Blisters erupt over the week and then heal over 2 weeks. Dental practitioners may be involved in the recognition of the oral presentation of shingles, right? Okay, here approach managing antiviral therapy for shingles indicate for adults and adolescents who are immunocompromised and present within 72 hours of onset. Present within 72 hours of onset, right? Onset of the rash. Then children who are immunocompetent and have severe or rapidly progressing infection regardless of the rash duration. Third indication, all patients with immunocompromise, including with HIV or other cancers, right? Regardless of the rash duration or who are taking the chemotherapy, right? Like that. Okay, so we have three indications. Adults and adolescents who are immunocompetent and present within 72 hours of rash, and all the immunocompromised patients and children who are immunocompetent and have severe or rapid progressing infection regardless of the duration, right? Yes. Antiviral therapy for shingle reduces the acute pain duration of the rash, viral shedding, and ocular complications. Where the antiviral therapy reduces the incidence of post-therapeutic neuralgia is a cutaneous. So, if indicated, start antiviral therapy as early as possible. So, when to use the antiviral therapy? This antiviral therapy is recommended for shingle if patient with disseminated diseases affecting 3 or more dermatomes or more than 20 vesicles outside the area of the primary adjacent dermatomes. Invasive disease like encephalitis, herpes zoster ophthalmicus. Very important is zoster ophthalmicus, okay? Or herpes zoster oticus, or we call it Ramsay-Hunt syndrome in a patient with immunocompromised and in patient with non-responsive or fulminant infection. Because oral antiviral therapy is appropriate for patients with shingles who do not meet about criteria for intravenous therapy. So when we consider the shingles, you need to understand what. Make a small chart and make like shingles. You need to know what is shingles, like a reactivation of. Then how it present, like how it present location, the painful loan or those. And then you need to understand the treatment, right? Treatment divide into two parts. First of all, treatment indications. Who need the treatment? Then after that, you need to divide it again into who need oral therapy and who need IV therapy. So IV therapy, there are three indications. So if three indication present, go with IV. If not, other cases like not either one of these present, you can go with oral therapy, right? Because these three are very important. Because in the exam they will give a scenario and they're asking which treatment, and the option you will get the oral one, oral antiviral, and the IV antiviral. So because of that, you need to have an idea about when to give intravenous therapy, right? Okay, and you can manage the acute pain with analgesia. In children, shingles is generally less painful. Most children do not require treatment. Okay, here. So oral therapy indicate valacyclovir, famiciclovir, acyclovir, those things. Okay, so intravenous one, acyclovir intravenous. You can use, right? And here switch to oral antiviral therapy after significant clinical improvement and continue treatment for minimum of 7 days. Like total, for with intravenous and oral, total 7 days, right? Longer course like 2 weeks may required in the significant immunocompromised cases, right? Is everything understandable for this shingles? Yes, I'll attach a proper picture as well. Okay, here they have. Okay, I have given a question. 70-year-old woman present to the rural GP for the emergency department with 24-hour history of severe, 24-hour history of, what's that? 24-hour history of severe right subcostal pain radiating to her back. The pain is constant, burning in nature, and unrelieved by paracetamol. She described the pain as 8 out of 10, severe and noted mild nausea. She she has a medical history of hypertriglyceridemia, gastroesophageal reflux disease, and osteoarthritis. So medications include atorvastatin, omeprazole, and glucosamine. She does not smoke and drink alcohol. Occasionally, with her last binge drinking episode 2 weeks ago, she is a retired school teacher and has no traveling recently. On examination, appears uncomfortable and guarding her right upper quadrant. Her pulse rate is 100, BP 130 by 75, respiratory rate is 16, SpO2 98, temperature 37.2. Then 4 hours after presentation, examination revealed the following. Okay, this is the presentation. You can see like some vesicles, right? Vesicles in a dermatomal distribution. So they're asking which one of the following most appropriate. So oral valacyclovir. So let's see. Patient present with a severe unilateral pain following the development of the vesicular lesion in a dermatomal distribution. This is how they are asking. Okay, they will give both intravenous. No, they have not given here. I don't know what is the fifth answer. They can give oral and IV as well. Okay, so because of that, you need to understand it. And the prodromal pain typically proceed by the rash in 24 to 72 hours, and the groups of vesicles on the erythematous base in the dermatomal pattern confirm the diagnosis. If blood work performed, elevated inflammatory markers and mild transaminitis would be consistent with the systemic inflammatory response. So oral valacyclovir is the most appropriate management. Antiviral therapy should be initiated within 72 hours of rash onset, reduce the severity and the duration of symptoms, right? Yes. Yeah. Okay, I hope it's understandable. Next case, elderly woman with acute back pain after squatting. The option is given lumbar spine X-ray, first line. Okay, we'll discuss this question. A 70-year-old woman presented the GP practice clinic for routine health check and she reports 6-month history of intermittent lower back pain and has noticed decrease in her height of 4 centimeter over the past year. She experienced the menopause at age of 52 and has never taken hormone replacement therapy. Her mother sustained a hip fracture at age 70. She has no other significant medication history and no regular medication is taken. She does not smoke or consume alcohol. On examination, she appears well. Her height is 158, her weight is 54, BMI 21.6, pulse rate is 72, BP 130 by 8, respiratory rate is 60. So SpO2 98 and the temperature 36.8. She has a mild tenderness over the upper lumbar spine. Neurological examination of lower limb is normal. So they are giving the which one of the following most appropriate initial investigation. So let's see why they are going with lumbar spine X-ray. Why? Why is that? This patient presents with several concerning features for vertebral fractures, significant height loss 4 centimeter, back pain, and multiple risk factors for osteoporosis, including age, postmenopausal status, and family history. Given these findings, lumbar spinal X-ray is the most appropriate initial investigation to assess for the vertebral fracture. So our case, elderly woman with acute back pain after squatting. So what do you think? What kind of fracture is this? What kind of fracture is this, doctors? After squatting, we just discussed, right? What kind of fracture is this? Compression fracture, right? Low trauma fracture, because just after squatting, here also we can see, but we can see a fracture in that case. Anyway, we have to do the X-ray, right? Doctor X-ray, because I have attached this question. Because like lumbar X-ray is the most appropriate initial investigation to assess for the vertebral fracture. So because of this part, I have attached the whole question, right? Okay. Next question. Okay, our last question, I think. Yes, this is the last question. Fever with diffuse pustular rash after flucloxa. This is the one question, and the recorder has given AGEP. So, what is this AGEP? Acute generalized exanthematous pustulosis. 1 minute. Okay, then other two questions related with that. Old man had Waldenstrom macroglobulinemia and myelodysplastic syndrome with pneumonia, penicillin given. After 2 days, patient got macular papular rash, some pustular lesion. Asked what would lead to definitive investigation. This is one thing. Then next question. Another Waldenstrom macroglobulinemia came patient had the rigors and fever with lower lobe pneumonia and was started already ampicillin. Then got the generalized vesicular rash. Asked for the management. Okay. So two different things. Okay. So first of all, we will discuss about. Okay. What do you think from this question? What do you think? Is it different or is the same or what you can think? What do you think? What is your opinion? Okay. Okay. What about this question? What you should do? The second question. Mm-hmm. Mm-hmm. Yeah, doctor. Okay, we'll discuss. We'll discuss. Yes, because I'll explain. Okay, here first we'll discuss this one. What is this AGEP? So one recorder has given this one. This is a rash after flucloxa AGEP. Okay, so what is this? Acute generalized exanthematous pustulosis. So what is it? It's a severe drug reaction. Common triggers are antibiotics, beta-lactams, macrolides, sulfonamides. So sudden onset of fever, diffuse sterile pustular rash, erythematous background usually appear within days of starting drugs. The clinical features numerous tiny non-follicular pustules start on face inter sorry intertriginous areas become generalized. Okay, start in some areas, then it can be become generalized. So fever, malaise, and neutrophilia is common. Mild mucosal involvement possible. So the diagnosis is best confirmation by skin biopsy. So what you can do, subcorneal pustules with the neutrophils you can see from skin biopsy. Then the management, stop offending drug immediately. Then you have to give the supportive care. What about in severe cases? Then you need to do the dermatological review and short systemic steroid sometimes used. This is the one that we call it pustulosis. So this is after what? This is after this, mostly after antibody. This is from the same note I got from the where I got from this is a derminate one. Okay, this is the these are the images. Right? It also like some kind of it also like some vesicles as well, right? It's actually pustules, but it seems like some kind of vesicle, right? Yes. Because of that the image, because pustules and vesicles are kind of same appearance, right? Because of that some doctors in the second case, okay, second case, lobar pneumonia was started already ampicillin, then he got generalized vesicular rash. Because of this vesicular part, some doctors are arguing this as what, this is like a shingle case. Shingle. Is it shingles or just still what? Is this still the hypersensitivity reaction, or what do you think? Is it a shingles or hypersensitivity reaction? What do you think? How to differentiate? Because those are the things that the trickier part. What do you think, doctors? Tell me. What do you think? Like your opinion. Yes. A still hypersensitive reaction. Why this rash occurred after taking ampicillin, right? Right? Right, doctors, because they have not mentioned anything, is anything about dermatomal distribution, but some doctors have argued with me during the exam week because of this vesicular. No, we have to go with antiviral. No, doctor. Yeah, then I explained them. I think the recaller has seen this question, this as like a vesicular, because can you see? It seems like kind some like this positives, right? Can see like some like kind of can misunderstand like vesicles, right? Even like if we also see something, okay, it's kind of like a vesicles, right? That's why, like, don't confuse only from that a recaller, like a one part, because the thing is, but you have to think very clearly. Because here they have given was start already ampicillin, then he got generalized vesicular rash. I think this is also the same pustulosis. Okay. Okay, so you have discussed. Then what are the important point? The onset of AGP is usually within 2 days of exposure to the responsible medication. So in our first scenario, they have given after 2 days as well, right? It's after 2 days, right? Here, already started ampicillin. I think can be after 2 days. There can be this pustulosis, right? And what else? Here they have given what they cause. Yeah, here typically AGP start on the face and the armpit and groin and then become more widespread. It's characteristic by rapid appearance areas with red skin, sudden started with the pinhead size sterile pustules. There are tend to be more disease in skin fall, facial swelling often arises, right? Here. Can you see it's also kind of seems like a vesicle? That's why I think this is the reason the Ricola has misdiagnosed it as like that. Okay. So here biopsy of the skin, you can see subcorneal pustules filled with the neutrophil. Like, okay. So remember, because I made that note from here, this one, so from Dermanet. And okay, so patient with AG EP are often admitted to the hospital for a few days, but patient can be managed at home if they are feeling well enough to eat and drink. New medicines should be discontinued following the onset of AGEP, particularly antibiotics, right? Treatment based on the relieving symptom, like a symptomatic, the supportive treatment. So those are the everything you need to know. So what you can do to, you have to do the skin biopsy to diagnose it. Definitive investigation, right? Then here you have to stop the ampicillin, right? The management first. You need to stop the ampicillin first. Doctor, that's all for the day one. I hope everything went smoothly and everything is understandable, right? Is any doubt for today's topics? No, right? Is there any doubt or anything that you need to ask or whatever? Tell me, doctors. Is everything understandable or clear? Right? Because now we just finish our first topic, first day recalls. First day recalls. And how do you feel about day one recalls? How do you feel about day one recalls? Is it good? Because this time the April recalls are like repeated in day one, like kind of good amount of April recalls have repeated. You can access the file after I upload it, right? You know you have the general link, right, Dr. Grace? Yeah. Okay, so I'll upload the link after the right after now because I have already everything has marked here. So video once it uploaded, you can check it in the I think after like 1 hour, you can check in the main link I have shared in the group, or I can share it again. So I will give update once the video is ready. But for now, I can just upload the file. Okay. Thank you so much, doctors. Why you are saying sorry? Yeah, it's totally fine. Okay, you can ask anything. Okay, so thank you so much, doctor. So we'll meet tomorrow, right? Tomorrow the time can be changed because tomorrow we have the general the our general class at 6. So yeah, I will start tomorrow a bit earlier, then we can continue, right? Okay, I'll give update tonight. Okay, doctors, have a good day. Bye bye, doctors. Yeah, see you soon tomorrow.